you are dealing with healthy patients. So dealing with healthy patients very important, where you cannot do a mistake that will cause a death or some serious issue because they are healthy patients previously. So it's very important. And also obstetric is the most is a field that has a lot of litigation issues. So it's very important to deal things in obstetrics with very mindful, very careful. Otherwise, you will end up in problems. So keep that in mind. And you will be given, I think, lectures in documentation and everything. So documentation is also a very important part here. So each and everything you will need to document. And if you don't know, if you come across any problems, do not hesitate to get your seniors' opinion. Don't try things alone. Get everybody. That is another take-home message I would like to give you. So today my lecture is about eclampsia, which is obstetric emergency. So I'm going to share my screen, and I doubt there's a problem with full screen sharing. So I would share screen partially. Right. Like this. Now, can you see?
Yes, sir. Can see. Need to make it full screen.
If I make it a full screen, will you be able to see? Right?
Yeah,
can you see now the full screen?
Okay, not yet.
Can you?
It's not full screen, just slide sleeve.
Now I'm shifting the slides. Can you see slides shifting in full screen mode?
No, sir, no.
Yeah, that is the issue. So now you can see, no?
Yeah, but slide by slide, we can see, not the full screen. Yeah.
Now you can see slide move, no?
Can see. Yeah.
Right. So I'm Dr. Asika, consultant obstetrician in Colombo East Base Hospital. So what do you know about eclampsia? Now, can they answer? There's, mics are muted by default. Can they answer me or their mics?
Yes, sir, they can unmute or they can use the chat box actually.
All right. Okay. So eclampsia is one or more convulsions in a pre-eclamptic mode. So what is pre-eclampsia? The pre-eclampsia is usually the hypertension with proteinuria. But there are new definitions also coming. Hypertension, even without proteinuria, if it has some organ damage, we can call it eclampsia. So basically, hypertension plus proteinuria we call pre-eclampsia, usually after 20 weeks. The basis of this pre-eclampsia or pathogenesis is in placenta. So when placenta develops, it comes after 20 weeks usually, in most cases. So if a convulsion happens in such a patient, we call it eclampsia. So usually it's a tonic type of fit, and it's an obstetric emergency. So any unknown convulsion after 20 weeks and postpartum, we should treat it as eclampsia until proven otherwise. So there are many types of many causes of seizures that can happen in a pregnant lady, for example, epilepsy, or other medical causes for convulsions. But if the cause is unknown or patient presenting with a fit, it's eclampsia until proven otherwise. That is the take-home message. And it usually occurs in antenatal period before delivery after 20 weeks. However, it can happen in postnatal or during labor. We call it intrapart. So it carries a significantly high maternal mortality about 2% and very high fetal mortality about 30%. Now, it has risk factors. So we categorize them as high risk factors and moderate risk factors. So high risk factors are background hypertension and hypertension or preeclampsia or eclampsia that has happened in previous pregnancy. So very important, where you had pregnancy-induced hypertension or preeclampsia in previous pregnancies, we start aspirin as a prophylactic measure in this pregnancy because it is the major risk factor. And the kidney disease is a major risk factor. Also diabetes and autoimmune diseases like SLE, antiphospholipid syndrome, and so on. Also, moderate risk factors like the first pregnancy, we call it nulliparity, and the maternal age about 40 years. Maternal BMI about more than 35, or family history of preeclampsia, pregnancy interval more than 10 years, and multiple pregnancy. These are moderate risk factors. So if you get 2 moderate risk factors, we still prescribe aspirin to take until delivery. Okay, now we are going to discuss the case so that you will have some idea how they present. So this is a real case happened in our hospital. So this is 26-year-old primary. So you see a risk factor with primary mother, and who had diagnosis of PIH, means pregnancy-induced hypertension. That means new hypertension coming in pregnancy after 20 weeks. So she was diagnosed PIH at 32 weeks and was on labetalol for blood pressure control. Admitted to the ward with headache at 34 weeks. So when she presented on admission, she had a moderate headache and no visual symptoms and no abdominal pain. So when a preeclamptic lady, then as I said, preeclampsia is hypertension plus proteinuria. When they present in symptoms like headache, visual symptoms, abdominal pain, shortness of breath, these are very, very serious. So symptomatic preeclampsia is very serious. So we call impending eclampsia, that is a fit is coming. So here she had a headache, is one of the symptoms of impending eclampsia. So blood pressure recorded was 170 by 100, pulse rate 110, and reflexes brisk, urine protein 3+. So what happened then? Management wise, they have taken blood for investigations and they have increased labetalol dose because she was on 200 BD and blood pressure is high. So understandably, they have increased the dose and monitoring started. CTG is normal. So always keep in mind that we need to look after the baby as well. So for the fetal well-being, here they have done a CTG. So always, as I said, we are dealing 2 lives simultaneously. It's very important. And patient developed a generalized tonic seizure in this background. So it is eclampsia. So the initial part would be, so these are the DDs, so differential diagnosis. As I said, Epilepsy is one, pre-existing epilepsy, and the metabolic causes like hypoglycemia and medication induced or neurological induced brain tumor, cerebral, these things are DDs. But first you need to attend the initial episode or eclamptic fit, right? So these are the investigations results. So it's not very important when you have the patient coming fitting, right? So management involves call for help. So as I said, you are not going to do manage yourself. You always call for help. That is a key thing, not only in obstetrics, in other emergencies as well, because more hands, more brains uh, will give a good outcome. So initial thing is resuscitation involves ABC, airway, breathing, and circulation, because you can have secretions in your mouth and that can obstruct airway. And then we start to control seizure, and then blood pressure control, and then delivery, and then monitoring. This is the plan of management in a patient with eclampsia. So soon after seizure control, then we need to control the blood pressure, because high blood pressure can cause cerebral hemorrhage. So it's a very catastrophic event if you end up in a cerebral hemorrhage. Maternal mortality is very high, more than 50. And delivery is the treatment. As I said, the placenta is the key factor. Here, the pathological factor, pathogenesis in the placenta. So however much you try controlling fit, controlling blood pressure, won't help. Delivery is the option. So after delivery, and then after delivery also you need to monitor. So patient should be ideally in intensive care setting. Intensive ICU monitoring is the key. Ideal monitoring, but some places, where some hospitals you don't have ICUs, so it's a very difficult situation monitoring these kind of ladies, especially blood pressure monitoring will be in beat to beat monitoring with arterial lines, because blood pressures are very high. Usually they involve in the infusions of labetalol or hydralazine, and very vigilant blood pressure monitoring in ICU. So as I said, the resuscitation steps A, B, C, D, E, left lateral, and then oxygen. So magnesium sulfate is the standard treatment for seizure control. So how we give magnesium sulfate is bolus plus infusion. So 4 gram of magnesium sulfate as a bolus, then infusion 1 gram per hour for 24 hours. So if by chance, usually the 90% of the cases is also after a single episode of seizure. However, some rare cases can have recurrent seizures. So in the recurrent seizure, the second seizure, we give a 2 gram as a bolus. So blood pressure control depends on blood pressure. If it is, as I said, more than 180 by 100, usually it's IV infusion, arterial line, and HDU monitoring. So delivery is the key, because the pathogenesis lies in the placenta. So without getting rid of the placenta, you will never have a control. So delivery is the only option once we stabilize the patient. So we are not going to deliver immediately. We stabilize the patient, we control blood pressure, and get other colleagues involved. Then we plan delivery, usually by C-section, because in this case, the fit has happened in antenatal period. So cervix is very unfavorable. However, if the fit happens in the latter part of the labor, if it's a fully dilated patient, So it's easier to deliver vaginally rather than doing a C-section. As I said, advanced labor, vaginal delivery is possible, then we can expedite vaginal delivery. So, ideal monitoring is in ICU setting, where you need to have arterial line monitoring for blood pressure, and also for PPH. It's very likely to happen in this kind of patients. And thromboembolism is another complication that usually associates with eclamptic fits. Right, that is the end of presentation. So basically, I think I have given a basic idea of eclampsia. It's very rare. I hope you don't see a case during your appointment, because nowadays we identify more patients with risk factors, and they are on aspirin prophylaxis, and they are on very close monitoring. Our obstetric care is now developed in Sri Lanka. So not like past days, the eclamptic fits are a rare event that you will see maybe only 1 or 2 cases during your lifetime. So I hope nobody will see a case um, during your internship. However, if you come across with a patient who is fitting, a pregnant lady who is fitting, number one diagnosis is eclampsia. That is very important because maternal mortality is high as well as fetal mortality. So that is why we give you this understanding and outline of eclampsia. So, any questions? Any questions? So we continue. Right. Somebody has a question. Aspirin 75. No, aspirin dosage is 150 milligram for prophylactic prophylaxis for uh, pregnancy-induced hypertension. Uh, does it can prevent DIC? It cannot prevent anything. It is a prophylactic measure. It can reduce the incidence of preeclampsia in pregnancy, but it cannot prevent anything. Preeclampsia or DIC. DIC is also a complication of preeclampsia, so they are associated things. DIC, thromboembolism, they are like a same disease set of complications that usually comes with this kind of patient. That is why they need ICU care. Any other questions? Is dyslipidemia is a risk factor for preeclampsia? Of course, it is not regarded as a risk factor because, as I said, now you need to be very clear about hypertension in pregnancy. So what I am talking now is pregnancy induced hypertension. That means a lady who was normotensive previously becomes hypertension during her pregnancy after 20 weeks. That is what we call pregnancy-induced hypertension. So it's a separate entity. The pathogenesis is in placenta, not in dyslipidemia or arteries, genetics, nothing. So it's a complete different phenomenon. Other thing is that patients who are who's having hypertension or having pre-existing hypertension becoming pregnant. So they are also having hypertension in the background of pregnancy. So they had hypertension before the pregnancy or undetected hypertension before the pregnancy, because in pregnant mothers we are monitoring blood pressure. Usually some ladies, they may have hypertension in the background undetected, so they can usually come into picture when they become pregnant. So that is why we say it's 20 weeks is a cutoff. So if somebody is becoming pregnant and known to have hypertension around 12 weeks, we say 12 weeks, 13 weeks. So it's more favor of pre-existing hypertension rather than pregnancy-induced hypertension. So it's very clear. We have to be very clear about these two entities. So pregnancy-induced hypertension, pre-eclampsia, eclampsia, this is a spectrum. Other thing is pre-existing hypertension, or we call chronic hypertension as well. So another problem. So dyslipidemia is a risk factor for chronic hypertension, but not for pregnancy-induced hypertension. So can you tell the doses of drugs used in emergency management of eclampsia while we are working as HO? So doses, it is in the presentation. I will go back. Eclampsia. So are you asking doses in eclampsia? Yes, it is in my presentation. I will share the screen. It's usually better I can tell you. So so the drug of preference is magnesium sulfate for seizure control. It's a 4-gram bolus plus 1 gram per hour infusion for the first week. So if we have recurrent seizures, we increase the infusion for as 2 gram per hour. So when we are giving magnesium sulfate, it's very important to monitor urine output. So that is why I said it's usually an ICU setting. However, urine output is very important. Renal function is very important. So if you have compromised renal function, we may not give infusion. We may just give still dose, the bolus dose of 4 grams, and then stop, because the magnesium sulfate is cleared by kidneys. So if kidneys are impaired, magnesium sulfate can reach the toxic levels. So it can cause muscle relax. It has a muscle relaxant effect. So it can go to respiratory paralysis, respiratory muscle paralysis. And yeah, that is the main risk or main complication that can happen in magnesium sulfate therapy. Labetalol is best than hydrolysine because hydrolysine reduces with acid. So labetalol is the drug of choice. If we have labetalol, it is the drug of choice. But however, if you don't have labetalol, for acute blood pressure control, we can use hydrolysine. Yeah, hydrolysine can cause blood pressure reduction at once. That's why I said we need to have very arterial line monitoring. So it can be detected or picked up, then our dose can be adjusted accordingly. So these days, there is shortage of drug. So labetalol is best. However, if it is not available, then we can use hydrolysine as an infusion. So if you don't have infusion, then it will be a problem for high blood pressure controls, because you oral drugs or injection, even we cannot have a swift BB monitoring. Yeah. Any other questions? It seems no more questions. So we can you can shift to the next presentation. You can shift to the next presentation. Is it available? Next
Yes, sir. Yeah, next lecture is by Dr. Lahiru on history taking. It's a recorded process, so we can start. So thank you very much. That was Dr. Asika De Silva, consultant obstetrician and gynecologist, base hospital, Monleria. Thank you, sir, for the detailed lecture. So next is history taking obstetrics. So it's a recorded version. We share now.
Go according to the trimester, first trimester, second trimester, and third trimester. There are specific details. Hello. Can I share my screen?
Yes, I can. Yeah.
Right. Can you see that?
Second. Yeah.
Okay. Good morning to everyone. Welcome to the workshop. So my topic is to give you a guidance on obstetric history taking. So first we have to assess what is the objective of taking a history in obstetric specialty. So the mainly the history taking is all about identify the risk associated with the pregnancy. So there can be certain conditions which can make the pregnancy high risk, or there can be condition which can be worsened by the presence of pregnancy, right? So we are going to go through sort of a what we call obstetric cycle. Right. So if we look at any reproductive age woman, they would belong to one of these stages, right? So they either be on pre-pregnancy or pregnancy. Those are the two stages, right? So in here, we are trying to sort of see at different stages, what are the things, what are the information we need to gather. So there are pre-pregnancy state, booking visit, where after confirmation of pregnancy, they would have a booking visit. This would be mostly done in a field. Sometimes they would directly go with, to a private sector, or then get referred to the government sector for tertiary care services. Then we would go according to the trimester, first trimester, second trimester, and third trimester. There are specific details which we need.
Dr. Lahiru, sorry to interrupt you. Can we make the slides full screen?
I can.
Okay.
Can you see?
Yes.
Right.
Yeah. Sorry.
Oh, if the slides are not coming, let me know.
Sure. Yeah.
Okay, right. So then when we follow this, then the next step is the birth. It can be a spontaneous onset vaginal birth, instrumental delivery, C-section. C-section could be planned or emergency. So we need to gather certain details about this. Then another pre-pregnancy period where they might be using contraception if they are sort of spacing the births, right? So every woman in reproductive age would belong to one of these stages, right? So let's move on to specific stages. So when we are taking a history, right, from a patient, this is sort of the model we'll have to follow. So all this, all the segments, we are trying to identify risk factors, screen and identify risk factors, which would help us to optimize the mother's or the baby's health. So starting with age more than 40 is called elderly mothers. Elderly mothers are at higher risk of medical problems like hypertension, preeclampsia, diabetes, higher BMI, high risk baby. Can be, we need to because that the age is an important factor. Then whether briefly we have to say so this is called gravida 2. Gravida mean number of gestation, right? Which number of pregnancy she. Then para mean parturition, that means how many times she has given birth, more than 24 weeks. Then 24 weeks to a miscarriage. Then C mean how many living children the patient is having. Then briefly you have to say if the previous pregnancy was complicated with preeclampsia and ended up with a C-section, briefly say that. Then at the onset, whoever listening to your history is aware about the obvious risk factors. Then they would bear that in mind when listening to the rest of the history. Then we move on to how many weeks is the patient at the moment. So this needs to usually be used to calculate this with this OBS field. But currently, as everyone is having smartphones, they can use a app to get this with higher accuracy, right? If you use a free app like ObWheel, this is very simple, right? Because this is very important. Whatever the decision you'll be making would depend on this. If you calculate the period of amenorrhea in an incorrect manner, this could have a very negative effect on the care. Sometimes a miscalculation might end up with a preterm birth because we haven't calculated it properly. Right. The next point would be history of presenting complaint. It can be, there can be diverse presenting complaints. Then you need to look at the chronological order, how it started, how it evolved, what is the current situation now. Then assess whether the patient is in labor by asking whether she is having contraction, if there is passage of bloodstream mucus plug, which is called show, whether there is passage of lico, that means rupture of membrane, and how's the baby's movement, right? Then we move on to past obstetric history. In past obstetric history, every birth, every pregnancy, we have to assess whether there were any antenatal complications, whether the birth occurred at term, whether there were any complications at birth. Then if it's a low birth weight, we'll have to screen for small for gestation age in this pregnancy with scans. Then postpartum period, whether there has been any complications like PPH, retained placenta, anal sphincter injury, perineal injuries, then postpartum eclampsia, fits, and infections, lots of problems. And another thing we should never forget is to screen whether they had any postpartum depression, because that's something we tend to miss if we don't specifically look for. Right. So the next would be to assess for past gynecological history. This is important if the patient had any history of, let's say, sexually shared infections, any surgeries like myomectomies, tubal surgeries. These would have implication on their reproductive health. Right. At the same time, you can ask in there, you can ask about whether they have used any contraception method, what are their experience with that, what kind of contraception method they are willing to use after the birth of this child, right? Then the next is past medical history. This is also vital because there are certain medical conditions which can put a pregnant mother's life at risk, like heart diseases, one of the main killers, when main cause of maternal deaths. Then there can be medical conditions like bleeding disorders, issues with connective tissue disorders. Um, Now there are a lot of women who get pregnant quite later in their life. So presence of diabetes, hyperglycemia, diabetes, high blood pressures, these things are becoming more and more prevalent. So all these conditions can have a significant effect on the pregnancy. Um, right. Then we move on to past surgical history. This is also important because if in case the patient needs to undergo a C-section, knowing about the patient's surgical history, therefore risk associated with the C-section is important. Let's say someone who had a previous laparotomy, needing an emergency section or a C-section, planned C-section, this need to be done by a experienced surgeons because of the risk of having additions and possibility of encountering bowel damages, bladder damages during the surgery. So obtaining a proper surgical history is important in these cases, right? Some of your patients might have had bariatric surgeries. Some of them might have had orthopedic procedures done, which would limit their mobility, which would limit their limit the positions they can take during the labor. So knowing about these things is very important. Then the next up is the medication. So patients nowadays can be on a variety of medications. So we need to assess whether these medications are safe in pregnancy, whether these medications would interact with each other, because there can be uh, uh, polypharmacy, multiple medications prescribed during the pregnancy. So we need to be aware of this. And whatever the medication the patient is currently on, make sure that those are suitable in pregnancy and the doses are appropriate. Then go ahead with allergies, assess allergies to medication, foods, and plasters, right? So if the patient has reveals that she's having allergy, assess the severity of allergy, right? Just to be simply saying she's allergic to something is not enough. Whether it's a minor allergy or major allergy, what has happened is very important, right? Then going into social history, mainly it's about support at home, whether there is any domestic violence. These things need to be looked into, right? Right. So that was the sort of the generic history template. Right. So in pre-pregnancy period, everyone we assess whether they are on folic acid, proper dosage, 400 micrograms, and whether they have had the immunity towards rubella. And they should be, if they are planning for the pregnancy, if there aren't any risk factors, then they are okay to go ahead. Then assess for medical and surgical risk factors if there are any. Depending on the presence of those, try to optimize those by referring these patients to appropriate specialties. And until those are optimized, make sure that they are using reversible contraception. Right. So the booking visit, next comes the booking visit after confirmation of pregnancy with pregnancy test at home. Booking visit is mainly aiming at health screening. So this is the place where we to take that a long history, assessing for each component. And at the same time, we would arrange booking blood investigations, screening for infection, screening for presence of anemia, diabetes, and then we check for blood pressure, urine for protein, these things. Then, depending on this assessment, we categorize patient into low risk and high risk. And also assess whether they are in need of aspirin. We will look into risk factors. Then would they need screening for FGR, small for gestation age, and whether they have risk of preterm birth. So depending on these risk factors, they get additional care. Then we arrange shared care with the field and hospital. First trimester, the main thing is to assess whether they had a dating scan. This is to confirm the expected date of delivery. But the main objective behind is to organize our antenatal care in an appropriate manner. Right. Then the patient might have minor complaints in pregnancy like nausea, vomiting, UTI, back pains. And another important thing is to ask whether they had any vaginal bleeding episode. If that is the case, whether their blood group is negative or not. Then also screen for infection during. There can be low-lying placenta. If this is the case with the previous C-section, we need to exclude possibility of placenta, morbidly adherent placentas. So after detecting this at 20 weeks, the confirmation needs to be done at 32 weeks if the case is a low-lying placenta. Then at 28 weeks, we arrange a OGTT and a hemoglobin test to screen for anemia. Then this is the time you might see patients developing hypertension or obstetric cholestasis. So we need to look out for all these issues. Then the third trimester is we have routine visits to check maternal and fetal well-being. Monitor the fetal growth with symphysis-fundal assessment. We chart it and see the pattern. Then we ask the patient to keep an eye on the baby's movement because it gives us an indirect assessment of fetal well-being. Then at the same time, we need to discuss about birth options depending on the patient's risk factors and previous histories. It can be term vaginal birth, elective induction of birth, discuss about instrumental deliveries or C-sections. And at the same time, have a small chat about the postpartum contraception because this is the time they can focus about this, right? Then if you look at the birth, it's induction. It can be either induction of labor or spontaneous onset labor. Then we need to gather information about duration of the labor, whether it's a prolonged labor or a very short labor, which we call precipitated labor. Then mode of delivery, whether it's a vaginal birth, instrumental birth, or C-section. In these cases, we need to look into what was the indication for this intervention and whether there has been any complication. If there has been any complication, do they have any implication on future pregnancies? Whenever you do an intervention in pregnancy, make sure that you speak to the patient and make them aware about its implication on future pregnancies and document that in your diagnosis card, right? So then comes to the third stage of labor. That would be from the time of delivery of the baby to the time of delivery of the placenta. Assess whether there had been any complications like PPH, retained placenta, or obstetric anal sphincter injuries. Blood transfusion, all these things need to look into. Then on the postpartum period, try to arrange a follow-up for any antenatally detected conditions like high blood pressures, high blood sugars, any problems, any abnormal liver functions. So you need to make it, put into a place a follow-up plan, and then talk about postpartum contraception and the need for pregnancy spacing. Anyone who has had vaginal birth, talk about perineal care. Anyone who had a C-section, you need to talk about recovering from a cesarean section. Then arrange follow-up depending on their need. So I think that brings to the end of my presentation about history taking in obstetric. So I hope you get some idea about why we need to take a detailed history uh, from a pregnant woman, and you also have a better understanding about documentations and arranging of both antenatal and
Next lecture is maternal collapse by Dr.
All of you all had some sort of a exposure in ONG as medical students, and some of you all were house officers and you all through this. And going through the program, I have noted that you all be having a very specific topics, especially regarding to eclampsia. I know you just had antepartum and postpartum hemorrhage. So I will stick to the main principle of maternal collapse and what is
Yes, can hear, sir. You can start. Can you all hear or you can't hear? Yes, I can see.
Okay. Good morning, everyone. It's a very good opportunity that you all are having to have a introductory program like this before you are starting your post-intern appointments. As I'm sure all of you all had some sort of exposure in ONG as medical students, and some of you all were house officers, and some of you all had some brief exposure as RHOs. But having said that, you will be posted into different parts of the country. Some of you all will be working in as SHOs in ONG units, but most of you all will be in other places where you may have to deal with all sort of patients with different complications. Now, I have 20 minutes to take you all through this, and going through the program, I have noted that you will be having a very specific topic regarding preeclampsia. Now you just had antepartum and postpartum hemorrhage. So I will stick to the main principle of maternal collapse and what is relevant to a pregnant woman. Now, having said that, now just go through this case first, and just while you are reading that, just think how you would deal in this situation. Now, this is something that happened very recently during the time when the MLTs and everybody on strike. This is a Mrs. White, 26-year-old mother of 2 children, presented with vomiting and loose stool for 1 day duration. She had a history of reflux symptoms for a few days and had a dull abdominal pain. Her cycles were irregular following delivery and was not on contraception. She could not recall her last menstrual period and was having ongoing mild period. And she was admitted to the medical ward. On admission, she was stable and there was no significant abdominal tenderness according to the notes, and symptomatic management were initiated. This was an earlier admission at early hours. But what happened in the morning around 7 a.m. was patient collapsed with a almost unrecordable blood pressure with a tachycardia and a very low pulse volume. Now imagine now, most of you all will be working in setup where you don't have a obstetrician coverage. And this may be a case scenario that you may be dealing with. Keeping this in mind, just think around this, and I will go through the lecture and we'll come to this case later on. Now, when we talk about maternal collapse, it's an acute event involving either the cardiorespiratory system or central nervous system, right? Which can lead to a reduced or absent level of consciousness. Now, this can happen during the antenatal period, any stage of in pregnancy, and even postpartum period up to 6 weeks. Some of the maternal collapse are not due to cardiac arrest. And most common cause for maternal collapse are the vasovagal attacks and epilepsy. Now, in pregnancy, the maternal collapse can be multifactorial. Now, you have to remember there are specific conditions which happen just because you are pregnant. For example, if you take eclampsia, amniotic fluid embolism, those are pregnancy-specific conditions. But at the same time, the mother can collapse due to non-pregnant reason. For example, the cardiac cause, right? Or iatrogenic causes, for example, as a result of anesthetic drugs or as a result of magnesium sulfate, which we use in the treatment of pre-eclampsia, eclampsia. So the approach, you have to always keep an open mind when you are approaching a collapse patient. You can't have a very tunnel vision of, okay, this is this. Even though sometimes it is obvious this is this, there are so many other contributory factors also. So it's always better to approach a collapse patient with an open mind, thinking that this could be related to a pregnancy or this could not be non-related to pregnancy. Now, you all had, I think you had just from the College of Anesthesiology yesterday, situation there, we talk about the 4H and 4Ts, right? Those are the reversible causes of collapse. Now, this slide shows its application in the pregnancy. Now, the 4Hs, if you take the hypovolemia, hypoxia, hypokalemia, and hypothermia. Now, hypovolemia, if you apply to the pregnant woman, is mainly due to the hemorrhage, but there can be a relative hypovolemia in cases of high spinal block or in like neurogenic or septic shock. Hypoxic event can occur due to the cardiac event, amniotic fluid embolism, hypokalemia, not major, there's no major difference in incident, but hyponatremia can occur because of the fact that we use oxytocin, and if you're not very careful about how we use it. For the T's, your thromboembolism, toxicity, tension, pneumothorax, and tamponade, the special concern comes when it comes to thromboembolism because amniotic fluid embolism, which is rare, but it's a very fatal condition, and unless you have a high degree of suspicion, it's very difficult to manage also. Pulmonary embolism, air embolism, myocardial infarction, all can lead to thromboembolism. Right? Toxicity can be due to your anesthetic agent. Also remember, it can be due to the medicine and also sepsis. Now, group A, streptococcus, group B, streptococcus, E. coli are the notorious organisms that can cause sepsis in pregnant ladies, and some of the damage can be mediated to toxins. And specifically related to the pregnancy, always you have to remember the eclampsia, pre-eclampsia entity, and also which can lead to intracranial hemorrhage. But resuscitation mother is not the same as a non-pregnant lady. Now, if you go through this slide, you can see there are changes in the systems which occur during pregnancy. The cardiovascular system increases up to 32 weeks. There is a 50% volume increases. The erythrocytes also increases, but the volume expansion is more. So there is a dilution anemia which reduces the oxygen carrying capacity. So the first line shows the systems that is involved, and then second shows the changes in pregnancy, and third one shows the physiological changes in pregnancy, how it implicate when you're trying to resuscitate a pregnant mother. Now, of course, the heart rate increases, right? And the cardiac output increases, but you have to remember after 20 weeks, the gravid uterus can have a significant compression of the inferior vena cava, and that can significantly reduce the venous return and the cardiac output. When it comes to bleeding, hemorrhage, towards term, nearly about 10% of the cardiac output is delivered to the uterus. So if you are going to have a bleeding, the bleeding is going to be a massive bleeding in a very short period of time. The systemic vasculature resistance is decreased, so there is more pooling, the arterial pressure is decreased, and the venous return is decreased. So your resuscitation of a pregnant lady, the physiological changes also come into a place, especially when you're seeing this lady at an early POA or an advanced POA. What happened to the respiratory system? Now, if you see the respiratory rate increases, the oxygen consumption increases because of the not as same as a non-pregnant lady. Now, if you go through this slide, you can see there are changes in the systems which occur during pregnancy. Now, if you take the cardiovascular system, the plasma volume splinting of the diaphragm, the functional residual capacity is reduced. There is laryngeal edema. So you have a pregnant lady whose oxygen consumption is small. So when they have a higher tendency to become hypoxic more quickly, and it's also the intubation is difficult. What happened to the other system? So the gastric motility is reduced and the lower esophageal sphincter is relaxed mainly due to the progesterone effect. So they are at a higher risk of aspiration. What happened to the uterus? Uterus is enlarged. That pushes the diaphragm up, splinting the diaphragm, and that reduces the functional residual capacity of the lung. Also, it leads to the aortic cable compression. The venous return and the cardiac out in this slide. As you can see, if you go through the first box, now your breast enlargement, laryngeal edema, and reduced esophageal tone makes this method difficult to intubate. And also they are at a higher risk of aspiration. So in a collapsed pregnant lady, securing the airway early is very important because the aspiration is also the acidity of the gastric content is increased in pregnancy, and the aspiration can cause aspiration pneumonitis, which you may recall, we call the Mendelssohn syndrome, which is a very difficult condition to read and very and the circulation. Now, due to the physiological changes, there is a dilutional anemia, so the oxygen carrying capacity is reduced, and the functional residual capacity of the lung is reduced, and there is the fetal placental unit. So when the patient is apneic, there is a rapid development hypoxia, and you have to make sure that you deliver early high flow oxygen. Thirdly, because of the aortic cable compression, the venous return cardiac output is reduced. So you need to displace the uterus from the right side of the uterus upward. You are doing a manual displacement. If there is no requirement for CPR, there's of course the possibility of tilting the patient 15 to 30 degrees to displace the uterus away from the inferior IVC. But if you have to go for CPR in the tilted this thing, you have to make sure that your compressions are perpendicular to chest. Uterine blood flow increases toward term, and term pregnancy can go up to 10% of the cardiac output. This predisposes to massive hemorrhage. So what you need to do is you have to make sure the bleeding is addressed as early as possible while the fluid resuscitation is taking place. How would you address the bleeding? If the baby needs to be delivered, yes, the baby needs to be delivered depending on the mode of delivery, depending on the situation. If there is written product which is causing bleeding, you need to make sure the uterus is evacuated. Or if the cavity, after delivery, depending on situation, if the ongoing is bleeding, you have to either opt for a balloon tamponade, uterine ligation, is a hysterectomy to control the bleeding. Having said that, let's come back to this first case I described above. Now, this lady was admitted to the ward. Can you hear me? Hello? And when the patient was collapsed, only the pregnancy test was done, which was found to be positive, right? And then now we are dealing with a collapsed patient. The approach for this collapsed patient is any other collapsed patient. You go for the standard ABCD approach. And the only thing is, if you have a pregnant lady more than 20 gestation, you have to make sure that there is no the aortocaval compression by either tilting this patient or displacing the uterus. Now, when you go through the resuscitation principles, right, it is as for a non-pregnant patient, your primary survey and resuscitation, you secure airway, breathing, circulation, disability, and exposure. Depending on the case, this not pertain to this particular case situation, you have to assess the fetal well-being and viability and decide the delivery. Then the secondary survey and the definitive care for the specific management. What happened in this patient? Sorry, just the slide has, okay. You remember calling for help is, you have to do at a very early stage. You are not working in a country or in a place where in a push of a button, everybody is going to come running for your help. So when you start managing, you call for help at earliest. Calling for help does not mean that you leave the patient and you go and make the call. You get ask somebody to get the people informed and get the help. So this patient, luckily, it happened in a medical ward. At that time, the BP was also there, right? So we, both the consultant and I got the call and the consultant anesthetic got the call. We rushed in. By that time, the airway has been secured and patient was on high flow oxygen. We got cannula in and patient is being fluid resuscitated. Unfortunately, we did not have a HB. This is there was this ongoing trade union action and investigations were not available at that time. The last known hemoglobin for this patient was around 10.8. But she looked very, very much pale. And like I said before, her blood pressure was very low, very low volume pulse and a tachycardia. So while the patient is being resuscitated, remember, although these are listed step by step, this process is a simultaneous thing, right? So you don't like go one from, you don't like go one after another. So the entire thing, even though this is listed one after another, this is a simultaneous process. So we did a bedside scan. There was no obvious hemorrhage and the amount of PV bleeding that she was having could not explain the sudden collapse. And did a bedside scan to exclude a concealed hemorrhage and see she had a gross hemoperitoneum. So she was stabilized in the ward and we transferred to the theater because now this is a lady with ongoing intra-abdominal bleeding. So whatever the resuscitation measures that we do is going to be temporarily unless we find the source of bleeding and arrest it. So we managed to get HB, that is also through the blood gas analysis, which became as 7, right? And while the blood being transfused, we did a laparotomy. She had about around 2 liters of a hemoperitoneum. There was a ruptured ectopic with active bleeding. We managed to successfully arrest it. And then we managed to save this patient and she went for discharge later day with a contraceptive method in plan. Right? Now, second case scenario I wanted to discuss you is again a postpartum lady. Now this is a lady, she's 34-year-old mother presented with a history of fits and altered level of consciousness on postpartum day 13. Now this is a lady who had an induction of labor for pregnancy-induced hypertension and she had a vaginal delivery and she was on nifedipine 20 milligram, nifedipine SR 20 milligram and had a good control. Her PET screening was normal before the delivery and postpartum prior to discharge and she never had proteinuria. But she had a 115 episode at home and another one on the way to the hospital. Now, this again could be one of the patients that you will be seeing where you all have been working. Now, on admission, her blood pressure was 190 by 110. She had a pulse rate of 103, regular pulse. Saturation was normal. Patient is edematous, afebrile, had an altered level of consciousness, reflexes were brisk, and tonus were more than 3. But her other system examinations were normal. She did not have focal neurological symptoms. Again, what happened was, again, early call for help, because again, you know, you can't be you won't be able to manage this patient alone. So while the being resuscitated, you need to call for help early, because she had a history of fitting. The airway was sucked out for sensation, ensure the airway is clear and no risk of expiration, and started on high flow oxygen via face mask with cannula in. Right? And the IV antihypertensives were started to control the blood pressure, and then the labetalol infusion was started to get a better control. The Maxwell bolus were given and the infusion started, the IV fluid started, and patient was catheterized. Investigation. So this is the initial management to stabilize this patient. However, what happened was, patient stabilized, blood pressure is all controlled, but the patient remained to have the altered level of consciousness, which is very much not normal when it comes to eclamptic fit, because once the eclamptic fit over, after the post-ictal drowsiness, the usual norm is patient recovers. But this patient does not recover and remain drowsy, while her other investigations are all normal. Then the next question which arises was, as we know, because of the high blood pressure, eclamptic intracranial hemorrhage. So we arrange for a CT scan unit for the treatment. She initially had treatment. She had a rebleed, however. After a very prolonged course in the hospital, and unfortunately, we could not save her. She passed away because of the complication of the rebleed from the berry aneurysm. So, having said that, I just want you all to take you through this algorithm also. Now, just go through it, because we have set algorithms for non-pregnant collapse. There is no set algorithm, the printed algorithm for the pregnant lady. So if you just go through this, you may have to make sure wherever you are, the environment is safe for you and the pregnant lady. Now, just assess the response. If the response is good, make sure you display uterus, call for help, assess the parameters, and identify the cause of the collapse. But if there's no response, you need to start the resuscitation process, right? So starting with the airway, check for obstruction, and if head tilt and chin lift. Assist the breathing for up to 10 minutes. If there's chest movement, listen for breathing sound, breathe in. Then you had to start CPR with the manual displacement of the uterus or with the left lateral tilt. Remember, if you are tilting the patient, the cardiac compression has to be at perpendicular to the chest, meters at the center of the chest, with 2 ventricular breaths, right? And remember, now this is when they are in the advanced facility, then you can asystolic, or the thereafter is going to change. But what is more important, doing examination, mind that you do you get definite help. Now, depending on which, it's always better to keep them informed in hand, saying that you are sending a bad patient, because then the receiving team can be ready to receive patient rather than being surprised when the ambulance comes. For those who will be working as big hospital, like general hospital, sometimes you have the PCUs where this patient does not come to the ward, but they can straight away from the OPD either goes to the PCU or the HDU, where you are being asked to come and review the patient. But in that situation, you are very lucky, because most of the initial management will be sorted by the PCU. But in places where you don't have a PCU or HDU, these patients will straight away come to the ward, or you all have to manage, stabilize, and transfer. Any questions that you all want to ask? Hello.
I think sorry about that. There's an issue with the bandwidth of the connections over here in the ministry. So anyways, we will share those lectures latter part in the sessions, right? So don't worry about it. So next lecture is by Dr. Juan de Silva, consultant obstetrician and gynecologist, DMH Colombo, on emergencies. Over to you, sir. So can you hear?
Hey.
Good morning to everybody. Roshan, can you hear me? Hello, can somebody, message me? Can you hear me? Okay, thank you. Right, so let me share my presentation. Right, so can you see my presentation? Is everything clear? Okay, right, so let me start. My name is Dr. Ruan Silva. Currently, I am working as a consultant at North Colombo Teaching Hospital, Ragama. So I should thank Ministry of Health for organizing this very valuable session on behalf of Sri Lanka College of Obstetricians and Gynecologists. Our president, Professor Sanath Lanarol, is really busy because we had our international conference ended last night. So then, so we are exhausted. So extremely sorry because I had to ask Ministry to, put few recorded presentations. Otherwise, we do it all the presentations as live. So anyway, so thank you very much. There's a big crowd has joined this session, right? So it's my duty. It's my duty to teach you about obstetric emergencies, right? So let me get on with my presentation, right? Okay, so emergency is not a uncommon thing for us as Sri Lankans. We had very bad time during war period, and bomb blast and things. Those are actually emergencies, right? You see, when in an emergency, a lot of casualties, people die, right? So in similar to that, obstetric emergency is a very dangerous situation, serious situation, occurrence that happens unexpectedly and demands immediate action. So emergency happens unexpectedly and which needs immediate action. So that is the basic principle of handling an obstetric emergency. So as junior doctors, you must know this obstetric emergency happens unexpectedly, very difficult to predict, right? But when it happens, as it demands immediate action, if you don't know how to handle it, the casualties are more, right? So when we consider the obstetric emergencies, we can categorize into fetal and maternal. So fetal emergencies and maternal emergencies, right? So my two colleagues, Dr. Rasika and Dr. Ziad, so early this morning, so did two lectures. So eclampsia is a maternal emergency and maternal collapse is a maternal emergency. But unfortunately, when mother is in danger, automatically fetus also become in danger. So therefore we are handling two patients, mother and baby. So these obstetric emergencies are very important because so if we act immediately, so if you act immediately, then what happens? We will be able to save mother and baby both. So maternal emergencies can be antenatal or postnatal. So eclampsia is an antenatal emergency. Postpartum hemorrhage is a postnatal emergency. So that is how we categorize these emergencies. Basically, emergency lecture is a full day course, but it's very difficult to do, such a way. But I have selected, so in an emergency where maternal and fetal or both mothers at a risk. So therefore I have selected, so shoulder dystocia, umbilical cord prolapse and uterine inversion, those three emergencies to be discussed within just 20 minutes, right? So let's get on with the first clinical scenario. So as a house officers, you will come across this scenario when you go to work, and when you start working in a obstetrics and gynecology unit. A 36-year-old multigravida with gestational diabetes mellitus on insulin has gone into spontaneous labor at 37 weeks of gestation. At the delivery of the baby, head is delivered, but trunk is not delivered with a gentle traction. So what does that mean? So if the baby's head is not delivered, you must not pull like a rope. So you must apply some gentle traction and see whether the baby's trunk is delivered. If the gentle traction does not deliver the baby's trunk, so that means there is a problem. So you are called by midwife to attend this emergency as a house officer on call. So what I'm going to talk in a few minutes, about shoulder dystocia. Shoulder dystocia is a fundamentally a mechanical problem. In an average gynecoid pelvis, at inlet, antero-posterior diameter is 12 centimeters, transverse diameter is 13 centimeters. If you take a cross section of the pelvis, the inlet is marked here, outlet is marked here. So when the shoulders are stuck at the level of inlet, that is the reason for shoulder dystocia. By the time head has exited the vulva, the fetal shoulders have normally traversed the pelvic inlet. If not, that causes shoulder dystocia. When the fetal head is delivered, if the shoulders do not deliver spontaneously, one or rarely both shoulders remain trapped above the pelvic inlet. So head to body delivery time is more than 60 seconds. You notice head came out, but 60 seconds has gone, trunk didn't come out. So that is shoulder dystocia. Very important. If you think the midwife has delivered the head by 30 seconds, 40 seconds, the trunk is not coming, you shout, this is shoulder dystocia. Don't pull the baby's head. It is shoulder dystocia. Head recoils against the perineum. Fetal neck is neither visible or nor palpable, which is called turtle sign. This is turtle sign. You see the baby's neck is not visible. The head recoils against the perineum. So if you notice turtle sign, don't allow midwife or nurse to pull the baby's neck. So that causes a lot of trauma and damage. So that is shoulder dystocia. There is a way of managing shoulder dystocia, right? So having said that, so what are the factors which increases the risk of shoulder dystocia? There are few pre-labor factors. There are some intrapartum factors. Previous shoulder dystocia, large baby, maternal diabetes, high body mass index, induction of labor. During labor, if the first stage is prolonged, if there is a secondary arrest, if the second stage is prolonged, if mother is on syntocinon augmentation, if you are going to perform assisted vaginal delivery, so you must predict there will be a possibility of shoulder dystocia. Unfortunately, shoulder dystocia is very unpredictable and unpreventable. At a time where you don't think it will happen unexpectedly, where you demand the immediate action like handling an emergency. Therefore, birth attendant is capable and skillful of managing shoulder dystocia. You go as a house officer, you live in the obstetrics and gynecology unit during that 6 months when you start your internship, you live there. So you are the one who must be able to handle at the initial stage to shoulder dystocia. You save mother and baby. So what are the sequences of shoulder dystocia? If you do not be skillful, if you don't know how to handle it, so if you end up with a shoulder dystocia which you do not manage properly, there are fetal injuries can happen, brachial plexus, fractures, birth asphyxia, hypoxic ischemic encephalopathy, intrapartum death. Right. So in case of maternal problem, maternal injuries such as postpartum hemorrhage, cervical, vaginal lacerations, bladder injury, perineal damage, uterine rupture, so on and so forth, like a lot of maternal complications, right? So coming to the important topic, right? So you must take a piece of paper and write down. when you detect a shoulder dystocia, when you think it is the shoulder dystocia, you shout, you call for help. There's no point in, starting something without, without asking for help. You must ask your senior house officer's help. You must ask your registrar's help. If consultant is around, even you can call consultant, sir, something is happening, I think it is shoulder dystocia. You immediately advise midwife, nurses to bring the buttock of the patient to the edge of the bed. Prepare the neonatal resuscitation. You call midwife, you tell midwife, immediately call baby doctors, pediatric doctors, and get ready with the neonatal resuscitation setup, because we are going to deliver a depressed baby due to shoulder dystocia. You need adequate analgesia, epidural, pudendal, perineal. So most of the time we use perineal infiltration. So inhalation analgesia such as nitrous oxide is available at some labor ward. Whatever available, you must use that, because you need adequate episiotomy, large episiotomy, to perform your maneuvers, calmly assist maneuvers to help alleviate the impact shoulder. Call for help means you call experienced obstetrician, neonatologist, anesthetist, and all other supportive staff. Right? Important advice. I have seen important advice. I have seen, some house officers, when you encounter with the shoulder dystocia, you push, from up and you pull the baby. So not to put a strong downward pressure. If you pull the baby, it is the most commonest reason for iatrogenic brachial plexus injury. And you must not apply fundal pressure. You should not do that, right, for the treatment of shoulder dystocia associated with high neonatal complication rates and may resulting uterine rupture. Very simple. You start with external maneuvers. You put the mother into macrobed position. It's very simple. The flexion of the hip and extension of the hip. You need two supporters. So ask one person to come from left side, another person to come from right side. You put the patient into macrobed position. So what they say is macrobed position itself will deliver the baby about 95%, right? So, and you can join macrobed position with the suprapubic pressure, right? That means you apply pressure externally just above the pubic symphysis. For that, you need to identify the posterior aspect of the anterior shoulder. So this is the anterior shoulder. Posterior aspect is behind. Why you apply pressure from the posterior aspect? When you apply the pressure from the posterior aspect, the shoulders, go like that, and the biacromial diameter is reduced. So both shoulders go like that, and the biacromial diameter is reduced. When the assistant apply a gentle traction, shoulders is delivered. So macrobed position, suprapubic pressure is the most important procedure each and every house officer must know. In case if you come across a shoulder dystocia, you believe 95-98% of shoulder dystocias can be easily developed by macrobed position. So no, we don't need another SHO or registrar or a consultant to put macrobed position. It is your duty. You must know what is macrobed position and suprapubic pressure. You must apply pressure in the proper side, right? So actually the suprapubic pressure, you must come from the baby's back side, not the front side, right? So in failing that, you need the SHO's help. If you are capable, you can perform, right? But usually in obstetrics and gynecology, you need senior house officers, registrars, senior registrars, and consultants always give a adequate cover to the intern house officers. We are available at any time. A senior doctor is available 24 hours. In few minutes, we will reach the damage, dangerous place and emergency. That is our way. Don't worry, we will cover up you. So internal maneuvers we can perform. Rubin 2, where you put your hand into the vagina to the fetus and apply direct pressure over the posterior aspect of the anterior shoulder. Wood screw maneuver is you rotate the baby 180 degrees, which will lead into the delivery of the babies, or otherwise delivery of the posterior shoulder, right? So all four maneuvers is another maneuver which is used by midwife in England. So when they put the patient into all four maneuvers, that also will be useful to deliver the baby, right? Third line maneuvers are we rarely perform. The obstetrician comes and perform. Failing all the maneuvers, we may go into symphysiotomy, that is cut the pubic symphysis, or cleidotomy, that is cut the clavicle, 7 mm and abdominal rescue. The take-home message for intern house officers is macrobot position and suprapubic pressure, very important. So moving to the second scenario, a 35-year-old mother in her second pregnancy undergoes artificial rupture of membrane at 38 weeks of gestation, as she's diagnosed to have gestational diabetes mellitus on insulin. Her pregnancy is complicated with fetal macrosomia and polyhydramniosis. After ARM, CTG was performed. Prior to start the syntocinone, midwife has called you to review the CTG. So the CTG lecture will be done today by my colleague, Dr. Chandana Jayasundara. It is very, very important. It's very, very important. So due to the situation, current situation in the country, so the litigations are coming up, right? So the CTG detection is solely your responsibility, right? So consultant obstetrician is a visiting obstetrician. So he doesn't live in the ward, right? So basically SHOs are also doing on call. So who live in the ward is house officer. Therefore, house officer is the person who must know how to interpret a CTG. At least you must know how to detect whether the CTG is normal or abnormal, right? So going to that. So this is the CTG. So you are called to review the CTG. What you see, so there is a baseline heart rate. It's around 40, right? The variability is slightly reduced, right? And there are some deceleration. So heart rate is coming down time to time. So basically, this heart rate is sometimes come down with the contraction, even without contraction also it's coming down. So we call this type of decelerations are variable deceleration. So CTG deceleration, variable, deep, late, lateral deceleration. So those decelerations are pathological. When a house officer see or observe such a CTG, the most important next step is, right? So you must do a vaginal examination. Why you do vaginal examination? You need to assess the cervical dilatation, whether it is fully dilated or not. If it is fully dilated, the mother is trying to deliver the baby. So we can support mother to deliver baby by an instrument delivery. You can call senior house officer. At the same time, you need to assess the presenting part, whether the presenting part is head or breech, and you need to exclude cord prolapse. So when you insert your finger into the vagina, if you feel something like a rope inside the cervix, that may be a cord prolapse. What you can do, you can put a speculum and see whether if you can see a white rope-like structure, that is the cord. So you diagnose cord prolapse. So these type of CTG decelerations appear in a cord prolapse. So what happens? Loop of umbilical cord caught between the vaginal wall and the fetal head, leading to diminished blood supply to and oxygen supply. The cord prolapse is mainly in an emergency for the baby, right? Nothing will happen to mother, right? So when the cord is compressed against the head and the vagina, what happened? The oxygen supply to the cord is cut off and the baby become hypoxic and fetal distress and death if you do not act very fast. So you need act very fast, right? So the risk factors for umbilical cord prolapse are fetal risk factors such as malpresentation, breech transverse lie, oblique lie, prematurity, small fetus, fetal anomaly, multiple pregnancies, maternal risk factors such as multiparity, contracted pelvis, pelvic tumors, so placental, minor degree placenta previa, amniotic fluid such as polyhydramniosis, which is the case in our case scenarios, is a GDM mother on insulin having polyhydramniosis in macrosomia at the time of artificial rupture of membrane, the cord has come out, right? So obstetric manipulations such as manual rotation of the fetus, forceps, ECB, ARM in high head are the risk factors. So what are you going to do, right? So first and foremost, you must ask midwife to check the fetal viability and push the presenting part away from the cervix, elevate the presenting part. So if you concentrate on this diagram, so this baby's head is the presenting part, which compress the cord. So if you try to put your finger and elevate the fetal head, so that will reduce the compression of the head over the cord. So the cord compression reduces and cord will continue blood supply to the baby. If the cord is compressed, the blood supply is reduced. So you put your finger in and elevate the elevate the presenting part. Don't remove your hand from the vagina. If you remove your hand from the vagina, it will come down and press the cord again. So ask another person to fill the bladder with the Foley catheter and put 500 ml of normal saline through the catheter into the bladder and clamp the catheter. So that means the bladder is full with 500 ml and you are lower down, you are pushing the presenting part up. The full bladder will push the presenting part up a little bit more up. So then the compression of the cord is relieved. So if you are going to handle the cord, you handle the cord very gently. If you touch it and handle it, so the blood vessels in the cord will get, compressed and it goes into spasm. So the ideal position is knee chest position or Sims lateral position with a pillow under the hip. So this is knee chest position. This is Sims position. So I have seen, knee chest position is performed for cord prolapse. So knee chest position is that. So if the uterus is contracting, you can give tocolytics, and for emergency cesarean section, you need anesthesia. So that is how you handle cord prolapse. So without taking your much time, I'm coming to the last clinical scenario. It's a 35-year-old multigravida in a third pregnancy, had an uncomplicated vaginal delivery 10 minutes before. Active management of third stage is done while midwife is delivering the placenta with control cord traction. Mother developed faintishness and you are called to attend to this obstetric emergency. You notice a whitish boggy mass at vulva. This is an true experience of mine when I was in house officer quite a long time before, right? So we used to have a cup of tea or coffee after the main ward round with our boss, right? Consultant obstetrician. So we were house officers. We were having just a coffee around 10:30 a.m. in the morning, right? So I got a call from labor room. The midwife is explaining the doctor, the baby delivered, but there's something abnormal I can see in the vulva. So I don't know what is that. They said it's a fibroid. So then I just ran. That's the first time I know I saw a uterine inversion, right? It's like a fibroid, right? The placenta is not separated. Placenta is attached. Some mass is coming out, right? This is what we saw, what we see, right? So the uterus has completely come out and it's attached to the placenta. So fundus turns inside out and goes through the cervix into the vagina, right? So due to vasovagal activation, parasympathetic activation, patient is now collapsed, near collapse. So what are the reasons for uterine inversion? Very important for you to avoid uterine inversion. Mismanagement of third stage. We will teach you active management of third stage is the syntocinon or ergometrine or symptometrine should be given at the time of delivery of the anterior shoulder, not after 5 minutes of delivery, not after 10 minutes of delivery. That is what is happening. At the time of delivery of the anterior shoulder, you must advise the nurse to give the syntocinon. Inappropriate fundal pressure or excessive traction of the umbilical cord. You apply control cord traction, not excessive traction. Abnormally short umbilical cord, sudden rising intra-abdominal pressure, morbidly adherent placenta, manual removal of placenta, connective tissue disorders such as Marfan, Ehlers can be risk factors for uterine inversion. What do you see clinically? Clinically, boggy mass appearing at the introitus. That is what I saw when I was a house officer. I ran to the labor ward. In the labor ward, the mother is lying on the bed and the mother is near collapse. One nurse is checking the blood pressure, but there's no bleeding, right? So what I saw is a white mass is at the vulva, which is attached, the placenta is attached to that. Severe sustained hypogastric pain, maternal shock initially out of proportion to the blood loss due to vasovagal stimulants. Uterus atony, postpartum hemorrhage and hypovolemic shock follows once you try to deliver the try to remove the placenta. Uterus not palpable abdominally, fundal dimple can be felt. So what are you going to do? Coming to the last few slides. So it's an emergency, you must call for help. Call for help, senior obstetrician, anesthetist, transfusion team, all the supports you call, right? So immediately you try to replace the placenta. So you hold the placenta in this way, right? Now the fundus in this way, you immediately hold the fundus in this way and push the fundus towards the umbilicus of the patient. So one with the pressure, so it might, the uterine inversion might be replaced. So then you keep your hand inside the uterine cavity, right? 2 wide bore cannula, needs volume replacement, blood cross match 4 units, and Foley catheter, analgesia for the procedure. So that day we tried the manual replacement, but it didn't work. It failed. So then we had to move the mother to the theater with the proper anesthesia. We have to replace it. Uterine relaxation and replacement. So if placenta is still attached, don't remove. If partially attached, you have to remove. Uterine fundus with or without the attached placenta is cupped in the palm of the hand. Whole uterus is lifted up towards the umbilicus. Once the fundus been replaced, keep the hand in the uterus while a rapid infusion of oxytocin is running to prevent the postpartum hemorrhage, which is going to happen after replacement of the fundus due to atonic uterus. O'Sullivan's technique is a hydrostatic method. Instill a large volume of fluid, 3 to 5 liters. See how much of the vagina occupied. 3 to 5 liters of the volume can be occupied by the vagina, thus distending the fornices and then replacing the uterine fundus back to the normal position. So prevention is much important, much better than the management of uterine inversion. So that is the obstetric principle. Traction is applied to the umbilical cord only when the uterus is well contracted. Counter pressure applied on the uterus above the pubic bone until the placenta is delivered. If control cord traction does not deliver the placenta within 30 minutes, you should not pull and pull and pull. So what you must do is, it is retained placenta. You must take the patient to theater and you do the manual removal of the placenta. So that is the end of my lecture. And sorry for our colleagues, some of our colleagues are unable to join live, right? So I should thank the Ministry of Health and I should thank the President of SLCOG giving this opportunity. And even in future, if you need any help from obstetric gynecology point of view, so you can contact our SLCOG office. So please keep these numbers if you are in trouble, right? If you are in trouble, so you can contact our seniors. We are always there to help you. So if you are encountering any obstetrics and gynecology problem in your team, with your consultant or any other problems, please convey that thing. You can contact us, by calling these numbers when you start your internship. Thank you so much for listening to my lecture. So if you want to answer any question, if you have any questions, so please ask, I can answer. So as I'm joining these sessions live. Roshan, shall we move to the next lecture, Roshan?
Yes, sir.
Yeah, so my another colleague, Dr. Chandana, will join, right? So we'll try to join him. He also live. So other presentations will be put as recorded presentation. Extremely sorry, some recorded presentations are not in that good quality, Roshan.
No, so I think problem with the bandwidth at the ministry, our internet connections. But anyway, we have these recorded, uploaded in the Google Drive. So
what about Roshan? My presentation is clear. All the presentation slides are clear.
Yeah, your one is clear, sir. You're presenting. Okay. No, when you share a video, is problem with the bandwidth.
Problem. Okay, then I do apologize on behalf of college and ministry.
But
thank you so much.
Recorded versions later part.
Yeah. Thank you so much for everything.
Right. Thank you very much, sir. That was Dr. Wandi Silva, consultant obstetrician and gynecologist at CNTH Ragam. So we'll move to next lecture by Dr. Chandana Mahoti, consultant obstetrician and gynecologist at Family Health Bureau on the theme of postpartum hemorrhage. So try to bear with us. We will share the recording, so there may be some clarity issues, but just listen.
Dr. Chaminda Mathur, I have 20 minutes to discuss obstetric hemorrhage. It's a bit of a difficult task to cover everything within 20 minutes. So I will try to mainly concentrate on postpartum hemorrhage and management of postpartum hemorrhage. And I will discuss a little bit about of blood from the genital tract within first 24 hours after the delivery. So if it is more than 500 milliliters, we call it postpartum hemorrhage. But if you can classify the postpartum hemorrhage, there are two main types. First one is a postpartum hemorrhage, that is 500 milliliters to 1000 milliliters. The major postpartum hemorrhage is loss of more than 1000 milliliters of blood. So there are two subcategories under major postpartum hemorrhage, that is moderate, that is 1000 to 2000 milliliters, and more than 2000 milliliters of blood loss is we classify it as severe postpartum hemorrhage. So if you consider the causes for postpartum hemorrhage, there are 40s. You all know during your undergraduate days, those 40s, tone, thrombin, those 40s. We'll discuss one by one. The first one is tone. So, antepartum causes and intrapartum causes can contribute to the postpartum hemorrhage. So, mainly the tone means uterine atony. So, the causes for the uterine atony during antepartum period, that is the antenatal period, where these are things that you can identify as causes: previous PPH, placenta previa, maternal obesity, large baby, multiple pregnancy, and induction of labor. Those things can contribute to uterine atony. Then during the intrapartum periods, if the labor is prolonged, more than 12 hours, so if there's a prolonged third stage of labor, not third stage, actually the second stage of labor, and sepsis can contribute to uterine atony. The thrombin means that is there any problem with coagulation that can lead to postpartum hemorrhage. So antepartum causes for coagulatory problems are preeclampsia, sepsis, use of anticoagulant medications, inherited bleeding disorders, and intrapartum you can have placental abruption, sepsis, DIC, those kind of things can lead to coagulatory dysfunction and bleeding. Then if we can talk about trauma, you can have uterine tears, cervical tears, vaginal tears, lacerations, episiotomy during the labor and delivery. In addition to that, you can have instrumental deliveries causing the traumatic delivery, or cesarean section itself can consider as a trauma that can lead to postpartum hemorrhage. The fourth T is tissue. that is either retained products of conception or retained placenta and membranes that or retained blood clots that can lead to postpartum hemorrhage. So if we consider the secondary postpartum, I'm going through quickly this theoretical part because you all know those things. Causes for secondary postpartum hemorrhage, infection is the main cause. So the things that can lead to infection are retained products of conception and prolonged rupture of membranes, pre-labor rupture of membranes, urinary tract infections, if any infection, postpartum sepsis, postpartum uterine infections that can, those are the things that can lead to secondary postpartum hemorrhage. So if we consider about the key facts about postpartum hemorrhage, most cases of postpartum hemorrhage occur within first 24 hours after the delivery, and there are no identifiable risk factors. That is the important things. Most cases, antenatal period, you do not identify any risk factors. So we have to be vigilant on each and every woman in labor, and we have to identify, if you are to identify all the postpartum hemorrhages and treat them. Then 70 to 90% of the cases, PPH is due to uterine atony. So active management of third stage of labor can prevent 60% of uterine atony. So the main thing you can do during your practice is to manage the third stage activity. That can prevent 60% of uterine atony. Then oxytocin, use of oxytocin reduce the risk of PPH by 60%. That is the routine practice in Sri Lanka. We use oxytocin in all the women who delivers. So that can reduce 60% of the postpartum. And most cases of BPH can be managed medically, such as uterotonic drugs like oxytocin, prostaglandin analogs. And if there's a surgical intervention is necessary, the first line is uterine balloon tamponade. So it can also prevent most of the other surgical interventions. If the uterine tamponade works, then you don't have to go for other methods. Then hemostatic suture techniques like Wheeling sutures can reduce the need of hysterectomy. Selective arterial embolization, which is not available in most of our hospitals, is an alternative to surgery. You can embolize the uterine artery and stop postpartum hemorrhage. However, we have to consider hysterectomy sooner rather than later in case it is necessary, especially in cases of placenta accreta spectrum and uterine rupture. So if you select to go for hysterectomy earlier, you can prevent most of the maternal deaths that are due to postpartum hemorrhage, because the delay in taking the decision to go for hysterectomy is the cause in most of the time when the mother dies due to postpartum hemorrhage. Then active management of the third stage of labor, you all know, controlled contraction, uterine massage, giving oxytocins, those things contributes to prevention of postpartum hemorrhage. Then if you talk about management of postpartum hemorrhage, we have to do 4 things simultaneously. That is communication, resuscitation, monitoring and investigation, and arresting the bleeding. You can't do these 4 things step by step and manage postpartum hemorrhage. First, you do the communication, then you do resuscitation, then monitor, then arrest the bleeding. It is not going to work. So you have to do the communication, do the resuscitation, monitor the patient, do all the investigation while arresting the bleeding. That's how you manage postpartum hemorrhage. So if we talk about communication, you have to call for help, call the key persons like the anesthetist, consultant obstetrician, and assistants, midwives, nurses, other doctors, and inform the laboratory, hematologist, all the team that you need to manage the postpartum hemorrhage. That is communication. This is an ongoing process. You can't call for help and stop. You have to continue in the communication step while resuscitating also. So the resuscitation, initially you start with ABC, airway, breathing and circulation, oxygen via the face mask. You have to monitor and keep the records at the same time, and use 2 wide bore cannulae. Keep the woman warm. And rapid infusion of fluids, again using warming device, because hypothermia can lead to the problems while resuscitation. You have to use the fluid warmer or keep the woman warm. That is also important. Then you have to do the laboratory investigations, monitor the urine output, CVP, insertion of CVP line if the experienced staff is available, then cross-matching and starting transfusion as soon as possible. Those are the things that you do during the resuscitation. And main therapeutic goals of management of massive BPH, you have to maintain hemoglobin level more than 8 grams per deciliter, platelet count at least 75, then prothrombin time less than 1.5 of times the mean control, then APTT less than 1.5 times, then fibrinogen levels more than 1 gram. So while you are managing the postpartum hemorrhage, you have to investigate and treat the cause. So if it is urinary, you have to treat accordingly with the uretronic medications. If it is retained products, then you have to remove the retained products. If it is trauma, we have to repair it. If there's a coagulation deficiency, then we have to correct it using appropriate coagulatory appropriate blood products. So most common cause of primary BPH is uterine. However, if the clinical exam, you have to do the clinical examination at the same time to exclude other causes, like what the things I mentioned before. So management of BPH due to uterine atony, I'm not going to go through all the medications. You all know how to use oxytocin, ergometrine, misoprostol, carboprost. Those are the medications we commonly use, and the doses and how to administer them. Then if we discuss about surgical management, first step is to go for uterine balloon tamponade. If it is not successful, then we have to decide whether it is due to trauma. Then in that case, you have to repair the trauma, vaginal lacerations, vaginal tears, cervical tears, whatever the trauma, then you have to attend to that. Then if there's any retained products inside the uterine cavity, you have to do the manual removal or the surgical evacuation. Then if we consider vascular ligation or occlusion, then first line is the ligation of the uterine arteries. If it is not successful, or if you think that uterine artery ligation is not going to be useful, then the next step is to go for internal iliac ligation. And at the same time, we can think about going for hysterectomy. Resort to hysterectomy, either total or subtotal, should be taken sooner rather than later. As I mentioned earlier, especially in cases of placenta accreta, spectrum disorders, or uterine rupture, we have to decide whether to go for hysterectomy as the first line. Then causes for secondary BPH, main cause is uterine infection or endometritis, retained products, retained placental fragments, or abnormal evaluation of placenta site. So the management of secondary BPH is approximately 10% of the cases will represent massive hemorrhage. So you have to attend it immediately. Then resuscitation, communication, investigation, and management plays the main role. At the same time, you have to treat the infection with broad-spectrum and antibiotics. So any questions about BPH before I go to postpartum, antepartum hemorrhage? So you can add questions to the chat box, or else we'll discuss a little bit about antepartum hemorrhage. Antepartum hemorrhage include placenta previa, placenta abruption, placenta accreta spectrum, and uterine rupture. So you all know what placenta previa is. There are two types of placenta previa, major degree and minor degree. And the other classification is type 1, type 2, type 3, and type 4. So placenta previa was originally defined as placenta developing within the lower uterine segment on transabdominal scan and graded according to the relationship between the lower placental edge and the internal of the os of the cervix. So grade 1 is minor previa, grade 2 marginal previa, and grade 3 is partial. Grade 4 is the complete previa, which completely covers the cervix. So management, if you antenatally diagnose placenta previa, the major decision is to keep the woman as an inpatient or outpatient. The decision depends on a lot of things, including the distance from woman's house to the hospital, mode of transport, and the degree of placenta previa, whether she had antepartum hemorrhage or not. So all this contributes to this decision. Then use of antenatal steroids in case if she needs early delivery. Then delivery, the mode of delivery, depending on the exact site of the placenta, whether it is anterior or posterior placenta previa. Then if we talk about placental abruption, it is defined as premature separation of the normal sighted placenta from the uterus. The prevalence of abruption in European countries is around 3 to 4,000 pregnancies. 70% of the cases of placental abruption have been found to be in low-risk pregnancies. So you cannot identify risk factors in most of the cases with placental abruption. However, it can lead to maternal and fetal complications. If the placenta previa happens, that can lead to maternal infection, anemia, shock, coagulopathy, postpartum hemorrhage, fetal-maternal hemorrhage, and psychological consequence, even maternal death following DIC. Then fetal complications can be intrauterine death, hypoxia, anemia, fetal growth restriction, and preterm birth. So management of placental abruption will depend on gestation, signs and symptoms, and mother's cardiovascular status, and evidence of fetal compromise. If there's any evidence of fetal compromise with the placental abruption, we have to deliver immediately. Then if the mother's condition is deteriorating, we have to deliver. Otherwise, we can monitor, we can balance the risk of prematurity, risk of massive hemorrhage, and decide the time of delivery. Then placenta accreta spectrum. So you know the placenta is lightly attached to the uterine surface, and it separates after the delivery without any problems. But if the placenta tissue invades into the myometrium, we call this placenta accreta spectrum. It's a spectrum of disorders, starting from placenta accreta, that is morbidly adherent placenta, to placenta percreta, where the placenta invades and goes through the myometrium and enters into the serosal surface of the uterus. I'm not going to discuss details about the placenta accreta spectrum, but that is a severe condition, serious condition that can lead to maternal death. So if we identified it antenatally, then we have to manage it in a center where on-site blood transfusion is available and experts available to manage it. Then vasa previa is a rare cause of antepartum hemorrhage, where the bleeding comes from the umbilical cord the vessels in the umbilical cord. The significance of this bleeding is this is the blood from the fetus, not maternal blood. So you can have a small amount of bleeding and severe fetal compromise if the vasa previa is the cause for antepartum hemorrhage. And the visceral peritoneum. So it can again lead to antepartum hemorrhage, and it can bleed during uterine rupture and placenta percreta. It can bleed into the abdominal cavity, peritoneal cavity, rather than having a sign, rather than detecting it as an antepartum hemorrhage. So, are there any questions? Right. Okay. So, principles of management of APH. As I mentioned in postpartum, you have to do all these steps simultaneously. You have to call for help, do resuscitation, stop the bleeding, and monitor the baby, delivery of the baby. So, maternal resuscitation is the most important thing. In that case, while you're doing the resuscitation, we have to think about the coagulation, whether it's going into DIC, whether we need correction of the coagulatory problems. Then obstetric management, that is basically the decision on time and the mode of delivery, and use of antenatal corticosteroids. Then stage in development of DIC. So you have to do the blood test to check whether the coagulation is normal or whether she's going into DIC. Then the management of third stage of labor, and sometimes if the mother collapses, the going for a perimortem cesarean section. So those are the principles of management in antepartum hemorrhage. So I think I tried to finish
I hope you all could see that presentation clearly than the previous one. So next lecture is by Dr. Chandana Jayasundara on consultant obstetrician and gynecologist on CTG. Sir will join shortly, so stay corrected. Thanks.
Okay, good morning. I'm Dr. Chandana from University of Colombo. So welcome to your internship, and today I would be talking about today I'll be talking about the CTG. So interpretation of CTG for OBS and gynae. So the college has organized this because it's very important to have a basic understanding of the basic functions that is happening in the obstetric and gynecology unit, so that you will be much more acclimatized to go through this basic stuff and then come to a proper diagnosis and inform your consultants early when there are problems happening. So can you hear me clearly now to start? Someone tell me who's here.
Can hear, sir. Yeah.
Okay, very good. So then I can carry on. So I'm going to share my screen now. So it's about cardiotocography and fetal acidosis that I want to talk about. Now, cardiotocography is in one, I mean, we tell it in a short form, CTG. But CTG, why we do CTG is the most important issue rather than just obtaining a CTG. CTG does not mean we are trying to just check whether there is fetal distress as such, or whether the contractions are there very well or not. They are functions of the CTG, but the main objective of CTG is to detect fetal acidosis. And we all know, if you want to check fetal acidosis, rather than checking the heart rate and rather than checking anything else, most important thing is you have to check the acid-base status of the fetus. But we all know that that's not possible. That's not possible due to various reasons. Actually, we have fetal scalp lactate sampling or fetal scalp acid pH sampling, but that is very cumbersome. And you have to, the patient has to be in a labor room with an ARL to do that. And in countries like us, where the ABG facilities are not very widely available, it might be a problem. So CTG in that sense would be a surrogate marker to check the fetal acidosis acid base level instead of just directly checking the fetal acid. Problem with fetal acid base status is even if you do a ABG, even if you do a scalp lactate level, it would be one time thing. So you can't be just continuously checking the fetal acid level with a ABG. So CTG, the good thing is, though it is not a direct measure of fetal acid base level, but it's a continuum. So you can see the trends. You can see how the heart rate varies with different insults, maybe a contraction, maybe movement, maybe putting an epidural. So you can see how it changes in a very like it is a continuous way, right? So if you can see this CTG, now this is a CTG that I have shown here. Now someone might give you a CTG like this and ask, Doctor, me CTG kara tune bed ke patient ke gatte mogada doctor me again hita. Now, I mean, by the looks of it, you might think, okay, there is something bad. Okay, you can say, okay, the variability is also reduced. Okay, doesn't look okay, like that. So you will get different ideas, but that doesn't mean you know about the CTG. For you to make a decision about the CTG, you have to know in and out about the CTG. So I have devised this method where you check the probability of hypoxia. You look at the CTG and you tell what is the probability of hypoxia. That is the question mark that we have to check. So the probability of hypoxia, if it is not there, then we say this CTG is okay. If there is a probability of hypoxia but it is low, then we might say, okay, there's a low probability of hypoxia. And if you think these features are compatible with very high suspicion of something abnormal, then you say there's a high probability of hypoxia. And then you make your decision according to that. So what are the things you check? So you can check the baseline heart rate, baseline variability, and the presence of decelerations for you, to understand the probability of hypoxia. Right. So the most difficult journey we have traveled. So by the end of this lecture, you will be able to nicely categorize those CTG according to the probability of hypoxia. That is my objective. Anyway, so to start up, we all know that the most difficult journey we went through, actually we went through when we didn't know about it. That was our birth. Birth, delivering vaginally from the maternal birth canal would have been a terrifying experience. Luckily, we didn't know about it, right? And as obstetricians and gynecologists, and when you become intern house officers in obstetrics wards, it's your duty to make this a very dangerous journey as safe as possible. I mean, I'm not telling that you can make it 100% safe. I'm telling you can make it safe as possible. So that is the main objective of this lecture. So then we will discuss about what is this fetal hypoxia, how does it happen, and why do we know? So fetal hypoxia is a thing that happens with contractions. When there are contractions, there will be no blood flow. There will be no blood flow to the uterus at that time when there are contractions. So there will be reduced blood flow. And at that point, if the baby does not have adequate reserves to maintain the blood oxygen level stable, then the baby will get hypoxia. So that's the event where the fetal hypoxia happens. So we can always tell that if someone asks if is the fetal hypoxia abnormal during labor, it is not. I mean, without contractions, women can't deliver. So when you're having contractions, you are bound to have a hypoxic insult. But having a hypoxic insult always does not mean that the baby will be acidotic. Acidosis is a different thing. Hypoxia is a different thing. All the babies who become hypoxic does not become acidotic. Why is that? It is because of this. Actually, lactic acid forms with hypoxia because of anaerobic metabolism. Okay, someone is on in the mic, so off it. There's a disturbance. Yeah, better off the mics. And if you on it and then talk and then close it again. Right. Okay. So, so when you have fetal hypoxia, you will have lactic acid formation. With lactic acid formation, you will get metabolic acidosis, which is the dangerous thing. But luckily, we have buffers. We are not that vulnerable for acidosis. The buffer systems will come and buffer or mop these acids away. So the bicarbonate proteins and the hemoglobin buffers will mop it away. But at an expense, it's always at an expense. The expense is the buffers will be depleted. They cannot be replenished that early. They have to go to the kidneys and reform and come. And if you don't stop the insult long enough for these buffers to come back, then there is further increase in hydrogen ions where there are no more buffers to buffer it and reduce the metabolic acidosis damage. Now there, the enzyme systems get disrupted. And there you get an abnormal umbilical artery acid-base status where the pH will be reduced than 7 and the base deficit will be more than 12. And that indicates severe fetal hypoxia, which ultimately can result in fetal hypoxic ischemic encephalopathy. So repeated insult is the issue. Now you saw recently, now if you are being vigilant about the environment, recent news, some district court has given this thing that the government has to pay 30 million or something to a CP child. Now we have to understand what made them make a decision like that. It is not fetal hypoxia that made the decision. Everybody will look into fetal hypoxia. It's okay in labor. That will happen for every baby. But have you not done anything and allowed repeated damage, repeated hypoxia? and that will result in depletion of these bubbles and buffers, and ultimately developing acidosis that can harm the baby. So it is very important that once it happens, you act upon it. You don't have to go and you don't have to do a CSA in everything, but you have to see whether there is acidosis developing, right? That there are, and the CTG we try to take as a measure of the probability of this acidosis developing. So that's why the CTG is important. If you had done continuous CTG in who has been developed, then you will see decelerations coming in. You will see abnormal decelerations coming in, and finally only you will see that severe acidosis sets in and the baby dies, right? It is not a sudden event. So what is the methods of monitoring? Normally what we do is, in the first stage of labor, latent phase, fetal heart every 30 minutes, in the active phase every 20, and second stage fetal heart rate monitoring, where we just fix the fetal heart rate monitor to the baby, the CTG monitor, and let it run. Paper that much. So normally we don't have this continuous fetal heart rate recording mode available in our still. But if you have enough paper, you can do tool. You have to do it limit method of acquiring a CTG. So the position should be lateral recumbent or CTG machine with a Bluetooth enabled and allow the Bluetooth to connect to the machine. Sorry, I think I got a interruption with bad connection here. You can hear me right now?
Yes, I can hear.
Okay. So we'll go back to the lecture. Okay. So basic information of the pulse rate and the temperature. Very important, pulse rate and the temperature, because it can be maternal pulse that we are recording without knowing. So definitely the baby's pulse should be different from the maternal pulse. And the start time and the finish time should be recorded, right? Normally, tracing speed has to be checked whether it's right. Normally in Sri Lanka, we check 1 centimeter per minute. Again, it's unstable. Give me 1 minute. Right. And before starting the recording, you have to use the Pinard stethoscope or the Doppler device to correctly locate the fetal heart. And then only you have to put the CTG machine's Doppler probe into that area. You must not just put the CTG probe and start recording, because that might be a maternal pulse that you're recording, right? So very important, you use the Pinard or the handheld Doppler to check the fetal heart rate. And there you keep the probe. And not only that, all the intrapartum events like vaginal examinations, fetal scalp samplings, epidural, setting up an epidural or even epidural top-ups must be noted on the CTG. So you document it on the CTG. Patient went to toilet. Epidural inserted. Epidural top-up inserted. So in a 10 years time, even if you take the CTG, you would know why that CTG abnormality happened, because you have documented what has happened in your ink. And once you look at a CTG and you see the results, you always have to document what is your opinion about it and what you plan to do with it. That has to be documented in the CTG. Now we'll go to the basics of CTG. The basics of CTG, we interpret in 4 different areas. So we check the fetal heart rate, the baseline heart rate, and then we check the baseline variability, and then we check accelerations, decelerations, and yeah, so those are the 4 things: baseline heart rate, baseline variability, accelerations, and decelerations. These are the things that we need to interpret a CTG. Give me 1 minute. Hello? Hello? Oh. Yeah, sorry, I had a call from the ward, so that's why. Okay, so these are the 4 areas. Okay. So what is baseline heart rate? Oscillating. Oscillatory again. So the most horizontal and less oscillated fragment we have to find, and we check it where all the lines, all the up and down lines are cut, and we'll take it as the baseline heart rate. Now, here the or here, rather than taking here. Now here it is very difficult. We don't know where is the baseline, but here it's very clear. This area, I would say baseline heart rate is somewhere like this. Right? This where you take, give me one. Yeah. So baseline heart rate is where you take most of the area where there's less oscillatory fragments. Right. What is the normal baseline heart rate? Normal basic. Anything above 160 will be considered. Where it can happen in maternal infections, fever, epidurals, even fetal hypoxia cause. Now, gradually developing hypoxia, ultimately what is resulting is increasing fetal heart rate, right? And bradycardia is anything less than 110. So, both things you have to be careful. So, I talked about this. Then you have the baseline variability. Baseline variability refers to the oscillations of the fetal heart rate up and down in 1 minute small segments. So this is called the bandwidth, for example. I will show you a picture of that. Now you see bandwidth kila kiyanne me upstroke and downstroke together. Upstroke, downstroke together. Upstroke, downstroke together. Now remember that is the most important thing. Bandwidth. Metana bandwidth metana upstroke, downstroke gattama. This area is bandwidth. It's about 10. Metana upstroke, downstroke gatta metindala metanta me yana. That is about 15. See, 15. Like that, you have to understand what is the bandwidth. So normal variability is bandwidth of 25. Whereas reduced variability is anything less than 5, and increased variability is anything more than 25. Now remember, reduced bandwidth itself is not always abnormal. Why? The baby is sleeping sometimes, and when the baby is sleeping, there won't be a very active bandwidth. The bandwidth will be less. But luckily, babies don't sleep more than 50 minutes. Actually, more than 45 minutes, babies won't sleep. We give another 5 minutes more. So if the bandwidth is reduced less than 5 for more than 50 minutes, we are worried. We have to do something about it. Same thing, if there are decelerations, I will tell you in a short while what are decelerations. But if you have decelerations together with reduced bandwidth, we are very worried. That means only 3 minutes we can allow. If there are decelerations with reduced bandwidth, decelerations in the bed. Objectively. Take home message. The baby can't be nicely sleeping calm and quietly when you're having severe hypoxic insults. So that means there's something really wrong. So if there's reduced variability with decelerations, you're not going to wait more than 3 minutes. You have to go and try to deliver this child. Right. So you can see first trace is reduced variability. Second trace is reduced variability with decelerations. These are all decelerations. And if you see this trace, it is like a thin line. See, thin line. So the variability is also very much reduced in this trace. So variability reduced and decelerations are dangerous. Then you have increased variability. More than 25 weeks is called increased variability. It's called the solitary pattern also. Accelerations are very easy. They are abrupt increase in fetal heart rate for more than 15 beats, lasting for more than 15 seconds. By definition, they are, having accelerations is good, but not having acceleration does not mean the baby is really hypoxic and going to die. So you don't worry about it. But accelerations are by definition Increase in fetal heart rate for more than 15 beats lasting for more than 15 minutes. So these are accelerations, you see. Then there are decelerations. Decelerations, there are 3 types: early, variable, and late. Early decelerations, variable decelerations, late decelerations, though we have to discuss each and everything separately. By definition, a deceleration is less fetal heart rate going down baseline heart rate for more than 15 beats lasting 15 seconds. But then again, we have to know the several different types of them, right? There are several different types. What are these different types? Early decelerations, variable decelerations, and late decelerations. So just remember these basic parameters of different decelerations, because you will have to know it when you are interpreting CTGs. You can miss an acceleration but never miss a deceleration, because decelerations can be very dangerous, and that might wrong interpretation that might result in the life and death of the baby. So first thing is early decelerations. Very important points. They are mirror image of the contractions. Mirror image. They have a shallow and short lasting nature. So they just drop it down, they come up soon. Mirror image, shallow and short lasting. Number 3, begins with the contraction. It doesn't come later, it comes as the contraction starts, the deceleration starts. So they will be V-shaped. V-shaped. Again, patas gala pallehata ena, patas gala udata ena contraction ekak. V shape ekak wage thamai pennanne. Right? So these are the things that you have to remember in an early deceleration. So early decelerations normally happen due to head compression. And normally they don't have a hypoxic component involved, but you don't take it as normal totally, you say it is suspicious. So these are early decelerations, you see, very shallow, drops down, come back to normal soon, always coincide a contraction. Okay. Then you have variable decelerations. Again, very important salient points. V-shaped. And the variability is very good during the deceleration. Variability is a deceleration. In variable decelerations, normally there's a good variability in the deceleration. So there is no absence in variability, even though you have a deceleration. And they have a typical shape. They have a typical shape. There's upstroke, downstroke, upstroke, coming back to normal. Right? Someone has on the mic again. So you have to off the mics. Okay. Off the mics. Right? So they are V-shaped. There is this typical shouldering where there's upstroke, downstroke, and they have a good variability inside the deceleration. So deceleration variability on that. And the other most important feature of variable deceleration is they don't have any relationship to the contraction. Sometimes there are contractions and no decelerations. Sometimes there are decelerations and no variable. There is no variable deceleration, but there are contractions. Sometimes with the contraction, there are variable deceleration. Something like that. So there's total dissociation with contractions. Contraction is a pain. So they are the most commonest type. 80% of the time you see them. And they are not normally associated with fetal hypoxia. They are normally due to head compression or cord compression. But if there's severe drop in fetal heart rate, even in a variable deceleration, I will be careful. So this is a typical variable deceleration pattern, you see there's upstroke, downstroke, upstroke, and there's good variability in the deceleration. But there are features that are dangerous. Now, this is the normal variable deceleration pattern where there is a baseline, they go up, come down, go up, come down. But there can be abnormalities like give me 1 minute. So, late decelerations, typical feature is they start after the contraction. After the contraction. So, about 20 to 30 milliseconds later than the contraction, only the deceleration starts. And the deceleration is U-shaped, not V-shaped. U-shaped. There's a very broad base and they are dangerously dragging. And variability is normally not the best in a late deceleration. Variability is not the best. So these three features, you have to be careful. That indicates a late deceleration, and they normally occur when there is a fetal acidosis. And normally you have to do additional tests to see whether how bad acidosis is this patient. And if you take action, and you will have to deliver. These are late decelerations. You see, this is the contraction, this is the deceleration. See, there's a delay, and it is broad. So this is a late. See, after this is a late. See, this is a late. These are late decelerations. Now this was also late. You see, the variability is also less. These all decelerations are coming after the contraction. See, this is the contraction, this is the deceleration. This is the contraction, this is the deceleration. So there's a small delay. See, right. You can understand what I'm telling? You can hear me?
Yes, sir, can hear.
Okay, okay. So I have to know that you hear me. So I'm trying to discuss about this CTG pattern. So late decelerations are very typical where they come after the contraction, right? And they are U-shaped and the variability is not fantastic. Okay, those are late and those are dangerous. Late equals dangerous. Be careful. Then there's this thing called the prolonged deceleration, or we call it the single prolonged deceleration. Normally, all of a sudden, everything is okay. Suddenly, there's a drop in the CTG, the heart rate, and it hangs on there. So if the deceleration goes for more than 30 minutes, we call it a single prolonged deceleration. If it goes more than 5 minutes, you start rushing to the theater and you want to deliver this child. You see, this is a single prolonged deceleration. See, this one square is 1 minute. So 1 minute, 2 minutes, 3 minutes. Then one single prolonged vela. Meaning here and hammer vinadi ekama dangerous, 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 dangerous. Me lamaya ikman delete katta natta me lamaya marana. So that is called a single prolonged deceleration. Then you have to know about this sinusoidal pattern. Sinusoidal pattern is actually, you might mistake it for a good variability, but it is not a good variability. It is a pattern where, but the CTG itself goes up and down. The CTG itself, the CTG, the heart rate itself goes in a very regular up and down pattern, but that doesn't mean the in beat to beat variation is good. Now look at this. Now don't take the up one, it is a little bit, I mean, it's not enough magnitude. You can see this one. See, the variability is very bad. See, beat to beat variation. But with tiny line going up, coming down, going up, coming down. So these are called sinusoidal patterns. It's like sorry, I got is interrupted again. This hopeless internet connection. This dialogue people, they're telling they have broadband and everything, but they just are useless. Welcome to Sri Lanka. Anyway. So now I'm going with my phone. At least it will be more reliable, I think. Anyway. So right. So we were talking about fetal behavioral status. Fetal behavioral status can be of three types. One thing is baby sleeping. We call it fetal quiescence. And then there can be active sleeping and there can be active wakefulness. Now, for example, a CTG like this. You can see the CTG. Now, by the looks of this CTG, you might get misled. You might think you might think that this CTG is having increased, you might think that the CTG actually is having lot of decelerations, because by definition a deceleration is reduction in the baseline heart rate for more than 15 beats lasting for more than 15 seconds. By definition, these are all decelerations. But if you look very closely, there's a very good variability. You see. Now, variability is a very clear indication of a very happy baby. And unless there's very increased variability. Normal variability indicates a happy baby. Happy baby having each month decelerations cannot be explained. Then how can you explain this? You can explain this by the term active wakefulness, where actually this baby is playing too much that you are seeing actually accelerations. Maybe you are seeing all the accelerations, see? And baby is not in the baseline, and this is the baseline. So if you continue this type of CTG for some time and the baby slowly goes to sleep, you can see the baseline will drop down to this level and it will be good. So if you see like a trace like this, be careful. You might be misleading decelerations for active wakeful being, right? So then the catch about it is there is a good variability in that trace. You always have to look at the contractions. If there are more than 3 contractions per 10 minutes, it is adequate. So normally we want at least 3 to 5. Anything more than 5 per 10 minutes contraction, that is indicates tachysystole or uterine hyperstimulation. You have to reduce the SIN or try to reduce the contractions so that it will not harm the baby. So you need at least 3 to 5 contractions at 10 minutes. Anything more than that is dangerous. So right, once you take a trace, it can be normal, suspicious or pathological. So how are you going to decide on that? That is the important question there to understand. So it's like this. We will think about the normal, we will think about the pathological thing. Then you can work out what is suspicious. The baseline, what is normal? The baseline normal is 110 to 160. Remember. So then what is pathological? Less than 100. Then you know what is suspicious, no? You would know what is suspicious because anything 100 to 110 would be suspicious. Anything above 160 would be suspicious. Anything less than 100 would be pathological. Then baseline variability, 5 to 25 is normal. What is pathological? Reduced variability, increased variability, and sinusoidal pattern of variability. If you have these things, they are suspicious. You all know, sorry, that's pathological. You all know reduced variability is also always not pathological. You have to have it for more than 50 minutes. If you have a reduced variability for more than 50 minutes, then it is pathological. If less than 50 minutes, it again comes to suspicious. Right? Then about decelerations. I mean, you don't have repetitive decelerations, there's a normal trace. You have repetitive decelerations, it becomes suspicious. Abnormal is late decelerations and single prolonged decelerations. Late decelerations and single prolonged decelerations are pathological, whereas all the other types of decelerations are suspicious. So once you know about these different types of features, the baseline heart rate, the variability, and the decelerations, you make an interpretation. Probability of hypoxia, no, low, or high. So if you have all the features, all 3 features, baseline heart rate, variability, and decelerations, all are in normal range, you would say the probability of hypoxia is low. No. If you have any suspicious feature, maybe the decelerations are suspicious, maybe the variability is suspicious, maybe baseline heart rate is suspicious, then it becomes a suspicious trace. Anything pathological in that, or 2 or more suspicious features in that, then I would consider it a pathological CTG and try to act on that CTG. Right. So that is what I want to tell you. So Ultimately, when you go to the wards now, take home message, acquire the CTG in a correct way. That means the maternal position, the documentation, checking the maternal pulse, temperature, and using the PINA to locate the fetal heart rate, all these things. Acquire it properly. Document what your decision is and tell what you think about the chance of hypoxia, and always when what you do, you record. Basically, you want to inform the seniors, you want to continue the pregnancy, the labor, you want to do a cesarean section, whatever you decide, you write it in the ticket and in the CT, and know how to divide your issues with in relevance to CTG. That means baseline heart rate, baseline variability, and accelerations and decelerations. We get the basics of normality and abnormality. For example, the normal CTG trace would be anything between 110 to 160 with a baseline heart rate normal and variability normal and no decelerations and plus or minus accelerations. And any pathological CTG would be a baseline heart rate less than 100 with reduced variability, increased variability, or sinusoidal pattern with late deceleration, so single prone deceleration, or the pathological. And suspicious. So once you know these things, you can interpret a CTG and tell, I think the baby who we got this CTG from has a high risk of hypoxia. You have to do something. So what you do, that is also very important. What you do, once you have abnormal CTG, you must not go and do a seizure straight away. First, you resuscitate this baby, right? What you can do is, if she is on synth, you can stop the synth. If she is getting even strong contractions without synth, you give tocolytics, some medicine to relax the tummy. Here in Sri Lanka, we have, if she's dehydrated, you can give normal saline IV fluids to increase the hydration of the blood. If she is in abnormal position in the bed, you can tell her to stay left lateral or recumbent position. So like that, you try to alter the circumstances and see whether the CTG improves. If it still doesn't improve, you might have to go and do a CC. Okay, that's about it. Thank you very much. Someone has asked question. Let me see. You want the sinusoid? Someone has told to explain the sinusoidal pattern. Now, sinusoidal pattern. We come to this slide. See, now sinusoidal pattern is, now when you take a normal CTG, there will be beat to beat variation. So one beat will go up, one beat will go down, one beat will go up, one will be going down like that. But in sinusoidal pattern, beat to beat variation is low. See this line. See this line. This beat to beat variation එකක් නෑ. Beat to beat variation හොඳ වෙනවා නම් මෙන්න මෙහෙම යනවා. එහෙම නෑ. But the baseline trace is going up and down. And if you just check after some time, it will be like the shark's teeth. Now this happens due to acute hypoxia, like maybe fetal anemia, maybe a placental abruption, something like that. So sinusoidal pattern is normal if you have intervening parts of normal variability. මේක හොඳට හොයන්න පුළුවන් මේ වගේ pattern එකක් ආවොත්. මේ pattern එකේ මැද්දේදී normal විදිහට variable කැලියලා ආයෙ මේ විදිහට pattern එකක් යනවා නම් that means that is normal. But if you have continuously something like this, then that is abnormal. Then that is abnormal. So that is the sinusoidal pattern. Okay, I think I explained it. Okay, then I think we are over. Thank you very much then.
Right. Thank you, sir, for the detailed lecture. So we go to the next lecture on ectopic pregnancy by Dr. Ranjan. So
RC Fernando, ne? No. I'm going to discuss you with the early pregnancy bleeding, where I may be basically focus on ectopic pregnancy, and I will touch on bit of miscarriage as well as the molar pregnancy. We'll move to the next one, the definition. Yes. So what is ectopic? That is, if you well aware, it is a normal pregnancy. The problem is implantation. The site is not the usual normal site where usually we see in the anterior, posterior or fundal side of the uterus. But sometimes it can be in the lower segment where we call its placenta previa. We'll move. Yes, so into the implantation site, when we are starting the uterine, so ectopic can be inside the uterus. Yes, obvious. So if it is below the lower segment, you know there's a thing called isthmus. You call it annular ectopic. When you're going further down, that is the cervix, cervical ectopic. In between, you put your cesarean incision. Sometimes the ectopic can be there. So those are the cesarean ectopic. So when it is going away from the uterus, those are extrauterine ectopic, starting from tubal. That is most common. Almost all it is tubal ectopic, where accordingly the location of the tube we can categorize ampullary, isthmus, intestinal, and infundibular. So most of the ectopic out of the tubal ectopic, again from the ampullary region. So from the ovary, from the tube, it can be moved to the ovary, or it can be the primary site of the ovary. So that is ovarian ectopic. And when it is moving from the ovary to the abdominal cavity, sometimes the implantation can be primarily from the abdominal cavity or secondary. That is when the tubal ectopic or the ovarian ectopic can be aborted to the abdominal cavity as a secondary location, where maybe intraperitoneal or extraperitoneal, very, very rarely broad ligament. Shall we move to the next? Yes, so this is some graphical presentation of those major sites of ectopic, where I want to highlight you. So when we talk about this 1% of abdominal, it can be even in the abdominal wall, omentum, liver, or even spleen. remember, there was one emergency laparotomy, what I aware, by a surgeon due to the ruptured splenic, and they remove the splenectomy, and the histology reveal it is a ectopic. So anywhere it is possible, remember. So you may be saving a life. We'll move. Shall we move to the next slide? Yes, so this is an interesting case scenario. So we are 23 years old, university student who presented to the OPD with the usual gastritis symptoms, that is abdominal pain, epigastric pain, and some vomiting. And as usual, the OPD MO prefer thinking of she's having the GRD and some varices and want to get the surgical input and refer to the surgical ward. And there the patient condition bit deteriorated. Symptoms were more and more palpitation noticed by the HO, and got the senior opinion, and the senior, I mean the SHO surgical won't get medical opinion because of the palpitation. And by that time, there was a bit of the chest pain as well. So when the patient moved to the medical ward, they start with the troponin and ECG. ECG reveal it is the sinus tachycardia like 160s. And immediately they get the troponin, which was negative. And then they think, oh, there is a possibility of gynae, and then get the gynae opinion. And where, as usual, in the gynae team involved, they always ask for the HCG, which is not available. Luckily, by that time, the patient was in the ultrasound room having ultrasound scan, because the medical people want to do a ultrasound scan of the abdomen. And the ultrasound revealed there's a free fluid, and the urine HCG. When the patient returned to the gynae side, they immediately did the HCG, and which was positive. So the plan was, because by that time, now a couple of days has gone for the whole scenario, and the patient was almost collapsed, and immediately rushed to the theater and had an emergency laparotomy. So we will discuss based on this case scenario, the ectopic and what and where they have missed, and we will learn not to miss that important points. Okay, we'll move to. Yes, so when we discuss about the symptom, it is very vague. So if you know about the early pregnancy symptoms, all early pregnancy symptoms will be there. Other than that, so abdominal cramps and epigastric pain, that is what our case patient presented to us. And sometimes they, if they are married, and they may be complain during the intercourse bit of low abdominal pain, what we call the dysmenorrhea, dyspareunia. And yes, remember, when they are even maybe delayed menstruation without telling anything, you need to be suspicious when they are coming females. Okay, we'll move to the next. So there are some rare features. What our patient had the severe abdominal pain, this epigastric in our patient, or sometimes severe pelvic pain, that is when they are rupture or about to rupture, or sometimes they may be having faint, dishy, or collapse because they are hemodynamically unstable. Sometimes they can come with the shoulder tip pain because the hemopene that is irritating the diaphragm. Sometimes with the broad ligament ectopic, very, very rarely, or the posterior pelvic wall implantation, they can come with the just back pain. Okay, we'll move to the next. So when especially we are very reluctant to get a proper history, but remember, if you are having any doubt about the ectopic when you are seeing a patient, always think of any inflammatory or scarring condition to the tubes. I will be explaining a little bit in the next slide, and some hormonal imbalances and genetic abnormalities. These things will reveal with your proper history taking. I will explain while we are moving. Shall we move to the next? So, what are the causes that can cause the increased risk or chances of ectopic? That is the scarring condition, that is infection or the damage, that may be previous tubal surgeries, reversal of LRT, previous ectopic, or the infection like gonorrhea or syphilis or the other STI, PIDs, endometriosis, or even previous appendicectomy, those kind of things that cause pelvic infection and scarring and surgical interventions can lead to the increased risk of ectopic. Yes, and this is more explanatory what we have discussed. And you know, when they have a lot of pelvic surgeries like ERPCs, again, the tubes can be infected and scarred. Yeah, shall we move to the next? So remember, not like the good olden days, now our female population also increase percentage of smoking. So don't hesitate to ask about the smoking. And most of our female now getting pregnant when they are 30s. So the age has positively related with the increased risk of ectopic. And when they are getting older and they have very tight time schedule, they easily go for the assisted reproductive technologies. So increased risk of ectopic. Yes. So we'll move to the next. So what are the differential diagnoses, or what are the other possibilities that will mimic ectopic and its complication? Yeah, any ruptured corpus luteum, or the chocolate cyst, or the endometrioma, and which is ruptured, and the twisted ovarian cyst, torsion or the degeneration of fibroid. Torsion is the pedunculated fibroid when they are torsion, because you know during the pregnancy the fibroids getting enlarged and they undergo degeneration, so they can mimic ectopic, that means the pain, and the sometimes it will cause preflage, so it's very difficult to sometimes differentiate. And I will discuss more about the miscarriage at the last discussion. As I mentioned, we should not only focus on when they are coming with abdominal pain and female. There may be other surgical causes like acute appendicitis or the renal colic or the spleen rupture. Okay, we'll move to the next. This is a bit crowded slide where when the female who's in, especially in the reproductive age, presented with the positive pregnancy test. First of all, in our case, when pregnancy confirmation with the HCG, fluid. So stable, dead ectopic pregnancy, where the mass is small, then your decision will be depend on the beta HCG level. If the beta, then again, better to proceed with the surgical intervention. Because the rupture and having emergency and unstable patient is more when the beta HCG level is higher. But the beta HCG level is less than 1500, you can have the option of medical management, where you know the methotrexate is the treatment of choice. And the beta HCG is very low, then you can have expected management when the patient is reliable and very reliable person. So she is living close by to the hospital. So the expected management, you will follow up the patient. I will discuss in the next slide. So we'll move to the next slide, please. Yes, so when the patient is present with the pregnant patient who is location we don't know, we call it a pregnancy of unknown location. That is the other presentation. They are coming with symptoms, but you don't know where the pregnancy is because their beta HCG is positive. That means we think she's pregnant, but we don't know the location. If the patient is hemodynamically unstable, laparotomy is the answer. Why? You are rushing, and maybe, as I mentioned previously, it can be in the spleen or the liver. If it is ruptured, the golden 1 hour will save the patient's life. So the laparotomy is the answer. But when the patient is hemodynamically stable, and if still the patient is in uncomfortable, discomfort, pain, then proceed with the beta HCG, serum beta HCG level and the laparoscopy, because sometime you may be seeing the abdominal pregnancies where they may be leaking or about to leak. So go ahead with the, if you have the facilities, go ahead with the diagnostic laparoscopy with or without surgical intervention. And when the patient is comfortable, asymptomatic, HCG positive, in the scan, imagine you are not able to find the location. So the answer is repeat the beta HCG in 48 hours. So depending on the increase, we decided which category they are belong. That is, if it is more than 2/3 rise, we imagine it is a very early pregnancy. It's not large enough to visualize from your imaging technique. So think as a normal ongoing pregnancy and repeat in 1 week time. And if it is the increasing, it is more than, if it is less than 66%, the possibility of ectopic pregnancy is high. That means it is rising, but it is not more than 2/3, or it's double, not double. So where are the ectopic risk is more, we need the HCG ectopic. So that is the category we may be managed as expectant management. And if it is decreasing and it is the failing pregnancy, it's a location we don't know, but it is failing pregnancy. So in 1 week time, we will repeat the beta HCG and scanning just to realize it is further going down and it is a failing pregnancy. And if the decreasing is much more than 13%, then it is failed pregnancy. So repeat the urine beta HCG, urine HCG in 2 weeks time and just make sure it is complete. shall we move to the next? So when the patient who is coming with the when they are coming with the abdominal pain with the bleeding, so we have to have the diagnosis as well as the resuscitation hand in hand. So the diagnosis, as you all know, history, examination, and investigation, and the resuscitation is the ABCDE, where I think our previous speaker, Dr. Siad, discussed about major part of the resuscitation ABC. So I will touch on the ABC and we will discuss more on the initial diagnosis part and the initial management. That is what we are more expecting from you when the emergency is happening. So shall we move to the next? Yes, the history. Remember, it's the ectopic or the pregnancy. More common or the usually in the female who are in reproductive age, that is after the menarche and before the menopause. But remember, sometimes females are pregnant with their first period. That means they didn't attain menarche, but they coming with the bleeding and found to have pregnant. Cases are there. So basically, females are pregnant until proven otherwise. Remember that phrase. Females are pregnant until proven otherwise. So always when you are seeing a patient, remember they are pregnant. You need to prove they are not pregnant. That is the way forward for you to think. So always, if you are in doubt, remember to exclude the pregnancy before you treating the patient. And always ask about the LRMP. That is the history the OPD MO has missed in our case scenario. He forget to get the history of the LRMP. And usually the ectopics first 3 months. So they have missed the period and just maybe 1 or 2 months or maybe 3 months. Yes, think whether it's ectopic. And it's rather not a matter to whether it is married or not. In our case, she's unmarried and the university student. When we initial consultation, she's not sexually active, that is the history, but when you are dipping and when you are more closer to your patient, then slowly, did you have used the barrier method, how about the emergency contraceptive pills usage, like that, then only you will get the whole scenario and they will reveal, because then that's how you develop the trust with your patient, and it's very important. That part had a scenario during the OPD discussion in the sexual relationships, and we are more practicing our team to reveal that areas. So remember, when you are dealing with females, always try to explore that. In obs and gynae, utmost important finding is looking able to identify the anemia and the pulse rate. So you will able to save more life if you more concerned about your pulse and the anemia. So always go for the pulse rate and obviously the blood pressure and abdominal tenderness. And if you don't have the scan, just percuss and see whether there's a dullness. There may be flank dullness or shifting dullness because free fluid inside. And the speculum examination, you may be seeing bit of bleeding coming through os, adnexial tenderness, And when you are doing your vaginal exam, this when you push your cervix, it will be tender. We call it cervical excitation. Okay, shall we move? In our case scenario, they miss the urine HCG at the first consultation. If they did the urine HCG in their first consultation, very unlikely to end up with the theater in a rush with the emergency laparotomy. Hopefully, we may be able to do that particular case as an elective laparoscopic procedure, which is much more safer and good prognosis and less traumatic. But we miss because the OPD team unable to get the G. Always remember HCG and the urgent full blood count. They are not only the HB, the platelet as well. Because the bleeding, sometimes this is the first time the patient has undergoing a full blood count who is diagnosed with some kind of clotting with the platelet deficiency. So always ask for full blood count, not the HB. And the imaging, where you will see or may not be, sometimes you may be seeing only the free fluid. So if it is inconclusive, that means if you couldn't see the ectopic, go for the beta HCG, where after 48 hours, depending on the beta HCG rising, as we discussed in the previous, so we can diagnose the ectopic. Okay, we'll go for the next. Yes, this is the one I want to highlight because now you are starting your career. What we are more expecting as consultants, call for help when you are in the situation where the resuscitation, or when you are starting your ABC, you know you need to start ABC with the face mask and putting the large bore cannula and take adequate blood for the basic investigation like full blood count, DT, and the other basic investigation, maybe clotting. So once the hierarchy team come, they will ask whether you send this, that, this lot of, but you may not be sending those sample, but if you have taken the sample and preserve, when your consultant asks you want to send the sample. So remember, when you are putting a large book cannulas, take adequate blood for the future use. And always start your crystalloid very early stage, because the circulation need to be maintained whatever the available blood inside. So remember to start your these patients are young, they can tolerate with very low hemoglobin if you give adequate fluid intravenously. So the fluid resuscitation is very important here. While you are doing, remember, you may be having good clinical skills, the knowledge, but you know when the disaster happened, the golden hour is very important, where you have to do a lot of work within few minutes, where you need to have a lot of heads and hands. So always ask your co-HO to help. Always ask your the next unit HO to help you, because that golden hour, if you miss, you may be not be able to save that life, or you going to disaster. So call for more help before you calling to a consultant. Make sure your SHOs are around you and your nursing staff, your minor staff, because you need to have the supporting staff to send the blood to the laboratory, bring back the sample, send to the blood bank, and bringing back the blood, arranging the and you need to contact the theater, preparing the theater list, sending for the in our younger generation. So you need to develop that skill to get more help from more people, to call for help. We are not calling help enough. That is why we are asking for a lot of issues when we are facing for emergencies. Always remember, you need to coordinate with the theater, blood bank, laboratory, and the anesthetist. Sometimes when it is coming the beta HCG with the private laboratory, so you need to have a good coordination skills. So, and not the last, but what is most important, A, B, C, D, E, F. F is fasting in this case. So remember, they should be fasting at the beginning. Otherwise, when you are trying to send theater, the fasting may be issues. Obviously, when the patient is collapsed, nobody will care. But in other words, always remember to keep them fast and start it. Then you can keep even fasting for hours until you get prepared everything. But if patient is not fasting, then you're asking for unnecessary problem and unnecessary issues with the anesthetic team and your consultants. Always ask, when you are problem, just put them into. Yes. So as I discussed at the beginning, in the early pregnancy bleeding, that is mainly the more emergencies happening as ectopic, where the pregnancy is normal, but the site is abnormal. When it is miscarriage, where the pregnancy is normal, the site is normal, but the viability is under there's no viability, or the viability is under threat. That is what we call the miscarriage. It's a normal pregnancy, which is the viability is the question. The site is normal. When we compare this with the other issue with the early pregnancy bleeding is the molar pregnancy, where it is an abnormal pregnancy. Site is normal. So spontaneous miscarriages, that is the nature is deciding the pregnancy is not going to continue. And what is the induced or the iatrogenic miscarriage or the abortion is, we decide this pregnancy, it is in normal side and it is viable. We think we should not continue that. So under that, the medical induced miscarriages are when the pregnancy threat the mother's life in Sri Lanka. We advise the terminate the pregnancy. It is not a single man decision. It is a multidisciplinary decision when the patient, like some heart conditions, cardiac condition, kidney conditions, and some psychiatric condition. So we may decide the continuation of pregnancy is keeping the mother's life in danger, where we decided to go ahead with the medical termination. So it is a multidisciplinary decision. And the criminal, you all know that is most commonly happening when people think we don't want with that pregnancy, they are going for the medical termination. So it is illegal in Sri Lanka, but it's happening. So whatever the kind of miscarriage, most disaster is when going for the step in the step steps is the mother's life is in danger. Hysterectomy is
But
when
dia panas
the
kotor aja. Oh,
So this is the last lecture for today. It's about labor.
Okay, fine. Thank you very much. Thank you. Now, thank you very much for giving me this opportunity regarding talk about labor board management, partogram, and the Muse chart, which is a very important topic. I am aware that you all have undergone this training, and some of you are not had the opportunity to involve in labor board management. But anyway, it is my pleasure. The budding new doctors who are coming to Gin and Obs, as well as even you are a MO in a peripheral unit, you may day-to-day encounter labor ward management in your institution. And it will save babies as well as mothers. So in that situation, I think this is a very important topic, which is little lengthy topic, but I'll try my best to short it as possible. So I'm Dr. Tilakaratna. I'm Jayanga Tilakaratna. I'm the consultant obstetrician and gynecologist at Base Hospital. Now, my first slide, how to diagnose labor. Patients with abdominal pain. but intermittently. And it has another two important characteristics. One is it increases in severity over the time period, and it increases in frequency over the period of time. And labor pains are associated with progressive changes in the cervix, like progressively thinning out of the cervix, which we call as effacement, and progressive dilatation of the cervical os. So, and it also, labor pains associate with show, which is what we describe is as a sustained mucus, or it may associate with dribbling. It we use to take as a gush water coming through the vagina or rupture of membranes. So if any pregnant woman, whether she's in preterm or term, admitting to your ward with intermittent regular abdominal pain, which is increase in intensity and frequency over the time, which is associated with cervical effacement and progressive dilatation, you diagnose this patient is in labor. Right. Now, next one would be the stages of labor. Sorry that some of the slides is not sharing, I can see, but wait a minute. So, yeah. This is just to refresh your knowledge, the stages of labor. The stage, we generally classify labor into 4 stages. First stage, second stage, third stage, and fourth stage. The first stage again divided into 2 phases, latent phase and the active phase. So the next slide will show you the diagrammatic representation of latent phase, active phase of the first stage, and then the second stage, and the third stage. So what is latent phase? Latent phase is the start of uterine contractions or labor pains where the os is closed and it progresses to dilatation of cervical os up to 4 centimeters. Then what is first stage? Active phase is where the os is about 4 centimeters. From there, it dilates up to fully dilate, or what we call 10 centimeters. So then what is the second stage? Second stage is the time period between dilation of the fully dilation to delivery of the fetus. Then what is third stage? Third stage is the time period between delivery of the fetus up to the delivery of the placenta. So fourth stage is we consider as the time period in between delivery of the baby to delivery of the fetus and up to the 2 hours postpartum, immediate postpartum period. Right. So this is just to refresh your knowledge from the medical school as well as your intern period. Right. Now, next slide, I would like to move on is the principles of labor ward management. So this is the most important part. There are a little bit of variation in between units. However, I'm going to talk about the principles of labor ward management. This is the first principle is you have to take a decision whether to admit this patient to labor ward or not. So Second thing is we have to make sure maternal and fetal well-being during the labor process is satisfactory or adequate. Third principle, if the patient's progression of labor is not adequate, you have to think of augmenting the labor. Fourth is we have to try our best to maximize pain relief during the labor process. Then next is the assessment of the progression of labor. So everything will be graphic represent program is the next principle. So I hope you are clear, but I'm extremely sorry my slides are not work properly. Now, the first most important thing is decision to admit the patient into a labor ward. So, you know, the patients who get labor pains can be spontaneous onset, or it is after induction of labor due to several reasons. So during the latent phase, you are not necessarily need to admit the patient to labor ward, where you can manage these patients in antenatal wards. However, during the active phase of labor, patient should be admitted to the labor ward. If there's concerns of maternal or fetal well-being, the admission could be earlier than what I described previously. So next principle or the next topic is what we think is the augmentation of labor, where when the labor progression is not adequate, we have to think to accelerate the labor progression to avoid unnecessary prolongation of labor. So we use certain medications. The commonly used drug in our setup is oxytocin, and it has certain standard protocols which is laid down by the different professional colleges and authorities, and syntocinon should be titrated according to the uterine contractions, and our aim is to have 4 to 5 moderate to severe uterine contractions for 10 minutes if we want to achieve a vaginal delivery. So this is a unfortunately, I'm sorry, I'll try if I can. But there are different protocols. One of the protocols which is laid down by oxytocin dose calculated by milli international units per minute, which is administered via an infusion pump. You dissolve 10 units of oxytocin into a 500 ml of normal saline, and we administer starting from the 3 mL per hour, which gives about 1 millunit per minute, and every 30 minutes we assess the uterine contractions, and then we increase or titrate the dose by doubling the infusion rate. So starting from 1 millunits, it increases up to 2 millunits. Then next 30 minutes, it is going up to 4. likewise, we go up to maximum of 32 milliunits. So it is evident in a lot of literature, majority of women in augmented with oxytocin will achieve their delivery within this maximum limit of 32 milliunits of milliunits per minute dose. So nutrition before doing that. Right. Next topic is the pain relief. Yeah. Now, as I mentioned earlier, pain relief, the labor is a pain it's inhuman to leave a woman in pain, give them a pain free or at least labor process. So we have different methods of adequate with paracetamol or codeine, epidural analgesia, which is a very effective analgesic method commonly used in our country is the Entonox, which is the in other part of the world, like Western countries, they have other different methods like water bath, the water births. But my next important topic is assessing maternal as well as assessing the progression of the labor. So this is mainly done by also implemented in one piece of sheet. have 2 fetal heart rate recordings until baby delivers. When it comes to the second stage also has 2 parts, that is passive second stage and the active second stage, where the passive second stage is the period where the baby presenting part is descent through the birth canal. You have to monitor fetal heart rate every 10 minutes. And when it comes to the second stage, the fetal heart rate has to be monitored every 5 minutes, where the maternal pushing down or bearing effect is coming up. The important part of this is during labor process, even though this is a physiological process, there are many chances the babies may go into distress or fetal heart rate abnormalities to be happen. Unless we document it we record it first, then document, we are not able to identify early the fetal distress and sometimes end up in severe or bad neonatal outcome due to fetal distress. So this is what we are going to prevent by documenting fetal well-being on the partogram. Now, next is the assessment of progression of labor, where it has 3 components. One is the assessment of cervical dilatation. Second component is the descent of the fetal presenting part. I'm going to stick to the vertex than that clinically. Then we document what is the cervical dilatation in centimeters. This is again you gain with your experience how to measure cervical or the os dilatation by using your 2 fingers. And after 4 hours, you document the next progression of the cervical dilatation. With that, I'll be moving to the next important point, that is the drawing of the action alert line and the action line. You know that we expect pregnant ladies who are in labor, when they come to the first stage, they are to have at least 1 centimeter per hour progressive cervical dilatation. So for example, if you start at 5 centimeters first vaginal examination, then in 4 hours time, you expect it to have 9 centimeters. If you draw a line crossing these squares, you will get a straight line. But in certain instances, we may not come across such progression, where sometimes when you do a next vaginal examination, it might be slow down and it comes and touch on the alert line, which is the line that we expect it has to be progress in normally. But if the next vaginal examination shows that your findings are fallen on right to the alert line, that indicates there is slowing of the progression of labor. This could be due to several reasons. So you have to be alert and see what could be the problems associated with slowing down. So it could be less maternal hydration or less uterine contractions. It may be less pain relief. So you have to look into that and you have to correct it. And then the important thing is, as I said, we usually do vaginal examination in 4 hours time. However, if you come across such situation where your second vaginal examination found that cervical dilatation is not adequate, you may need to observe or assess this patient earlier than 4 hours, where it may be in 2 hours time. Now, in case the action line is drawn 4 hours to the right hand side of the alert line, where your subsequent examination, vaginal dilatation comes and touches on the action line or crosses the action line, that means there is a possible dystocia or the abnormality in labor progression, where if you think that, if you see that the contractions are not adequate, you have to start oxytocin or increase the dose. And also you have to check whether there is any disproportion in the enough liver. Might is continue obstruction expect. Simply there's a head of the fetus which is palpable totally abdominally. You can palpate abdominal palpate or fully palpable in abdomen, where when the labor process is started with the labor contractions, this fetal head starts to abdominal, the fetal head about 4 fingerprints above the pubic symphysis is called 4/5 palpable abdominally. Likewise, you go ahead and feel it is 3/5. When it comes to 2/5, we say that it is head is engaged, and it comes to a stage where you won't feel at all the fetal head through the abdomen, where you have to do a vaginal exam. When you do the vaginal examination, then you assess how it descends down in the birth canal vaginally. So it is measured in relation to the maternal ischial spine, where the lowermost part of the fetal head in relation to the ischial spine is called as the station. So if the lowermost part of the fetal head, that is again, you have to remember that is a bony part, and in relation to the ischial spine or at the level of the ischial spine, we call it station 0. Any station above ischial spine level, we call it as minus station, or any station below the ischial spine, we call it as plus. So it is documented in either -1, -2, -3, where presenting part is above the ischial spine, or +1, +2, +3 ischial spine. So this is one of the important part that we have to assess, because if the labor to be progress with the cervical dilatation, the presenting part of the fetus or the head has to descend through the vagina. Now, next small parts on the partogram is the color of Lyco. You know that we have to mention the color of Lyco. We see the color of Lyco when we do the artificial rupture of membranes, or when the patient presents with spontaneously ruptured membranes. So we define them as a clear lico when it's like watery, blood stain lico whether it's associated with blood, it stain the due to the show, a mixture of show with the lico, or it could be bleeding from the placenta, which could be like a abruption. So you have to be very careful about the fetal heart rate if you see a blood stain lico. Or sometimes you may see absent lico. That means you don't see the lico coming out. It may be due to head. It is lico is not there inside the amniotic, where again you have to be very careful. There are little distress can appear on this situation. Then lastly, the lico could be meconium stain. You know, meconium is a physiological thing which occurs, which passes from the fetus. This is like a stools or feces, but it depends on the concentration. We decide whether it's a thin, moderate, or thick meconium is present. So if it is thick meconium, suggests that there's a less amount of lico with a more concentration of meconium. In that situation, we have to more cautious about the fetal heart rate monitoring. Right. Next is the position of the presenting part. You know that in the labor process, fetal head engage into the pelvic brim in a horizontal position, where during the process of labor, it undergoes rotation and it comes to the favorable position, or commonly presenting position is the occipito-anterior position. What is occipito-anterior position? That is the arbitrarily decided point on the fetal presenting part, in this case, the occiput, in relation to the fixed part on the maternal pelvis, which is the maternal sacrum. So if the fetal occiput is facing opposite to the maternal sacrum, which is called occipito-anterior position, the opposite is where the fetal occiput is facing towards the maternal sacrum, that is occipito-posterior position. If the fetal occiput is towards the maternal right, we say it's right occipitolateral. If it is towards the left, it is called left occipitolateral. In between, you see right occipito-anterior, right occipito-posterior, left occipito-anterior, and left occipito-posterior. Why do you need to assess the position? In assessing labor progression, when it slows down, one of the cause could be malposition. I said the commonly presenting position is occipito-anterior, sometimes occipito-posterior, but other positions are considered as a malposition. Where it slows down, even the occipito-posterior position slows down the labor progression. So you know the cause for the labor slowdown of the labor progression. Secondly, if it is in second stage where the labor progression is slow, you are requested to apply instrumental delivery to for the delivery of the baby, where you need to know exactly what is the position. Without defining the position, you are not supposed to apply instrumental delivery, which increases the failure of the instrumental delivery and more harm to the baby. So that is why you need to have a proper assessment of position of the fetal head. And caput is a common normal abnormality you see on the baby's scalp, where the scalp edema occurs, and which doesn't have any significance on fetal pathology, but it obscure or it makes you difficult to assess the fetal position because this edema crosses the suture lines and occipital bones. Then molding, which is again during the physiological process of labor, you see the fetal head, the fetal scalp bones has to undergo certain amount of molding to achieve the vaginal delivery. So it is again categorized into 4 degrees, where 0 is there's no molding, suture lines are separated and bones are separated. In grade 1, where the bones are touching each other but not overlapping. In grade 2, where the bones are overlapping but easily with one finger pressure, you can separate the bones. Up to grade 2, this would be a normal phenomenon in physiological process of labor. However, when it comes to grade 3, where the bones are overlapping and it is difficult to separate easily by single finger pressure, which may indicate there is an obstruction to the passage of the fetus. Especially, it slows down the progression of the labor, as well as if you are planning to do an instrumental delivery in the second stage, you have to make sure there is no obstruction in the birth canal, where otherwise you will end up in failed forceps or failed vacuum delivery. So last bit is the maternal well-being, where you have to document maternal pulse rate. It's about every hourly like, and blood pressure every hourly like, unless patient is having high blood pressure. Then the maternal temperature to see whether the patient is having developing any fever, where you may need to give antibiotics, antipyretics. And the last row is the action. As a total, what is your action on labor process? So the backside of the partogram earlier, the previous partograms had the observation of 4th stage, both mother and the fetus. So this will ensure, yes.
Yeah, I'm sorry to trouble you, sir.
Another 2 slides only.
Okay, fine. So slides are not moving.
Just only 2 slides.
Yeah.
Yeah, exactly. That I understand.
Yeah, okay.
Right. So 4th stage is the immediate postpartum period after the delivery of the fetus and the baby, where you observe for 2 hours in the labor room to see whether there's any undesired effects are happening. If it is not, yeah, I think that now you can see these slides. Sorry. Fine. So if you did this 2 hours, and if mother and baby is well, from that you can send them both to the postnatal ward. So that finishes the first part, or the part of the labor process, and how we monitor and how we manage labor process. The last 2 slides are on modified early obstetric warning score, or the chart, which is a tool developed in other parts of the world, as well as now it is in Sri Lanka for some time. It aids to identify and manage a critically ill or deteriorating patient. It could be pregnant patient, it could be postpartum lady. So what we are measuring here is, you can see, is a normal physiological parameters of a pregnant or postpartum lady. It includes temperature, respiratory rate, pulse rate, systolic blood pressure, diastolic blood pressure, urine output, any vaginal bleeding, and whether uterus is moved to a side, or whether, and the level of the funds. So this has given a color code. That is the important thing in here. I will describe what is it. And if you find out any lady, any pregnant or postpartum lady who's having any problems where you have to start this, you start, and every 15 minutes you have to observe this mother. So what it says, if any of these this way, if all these parameters comes on green zone, that says, that indicates this mother is normal. So there is no any abnormality on this mother. So monitoring and indicate mother is normal. But when it comes to any two parameters fall on yellow zones, you have to be very careful, because this indicates this mother or the pregnant mother or the lady who's in some sort of danger, where you have your seniors, your consultant, your senior SHOs, and sort out what could be done to revert it to green zone. Any one of these parameters fall on us, again, inform your seniors and take corrective measures to bring back this mother further deteriorating. Now, why we need this sort of a tool is because it is difficult task to identify pregnant and postpartum ladies having abnormal signs, because one thing, we do not come across very commonly problems or very critically ill patients in our obstetric units. The cases are rare. Secondly, as you see, so what we are measuring is the physiological parameters of this patient, and most of these parameters differ from the non-pregnant level, and it mimics the physiological changes of the pregnancy. So by documenting these physiological parameters and using this color code, it will help us to identify abnormal physiological parameters. And the word we need to use is escalation. Escalation means we bring this abnormality to the higher level of care, where your seniors, senior SHOs, or your senior obstetrician. And as a team, you all make a plan to diagnose what is going abnormal and how it bring back to normal, rather than late detection of the abnormal signs and symptoms. Now, why we need to use this is, this will definitely helps to reduce maternal morbidity as well as maternal mortality. That is one of our key objectives in providing safe labor for women in this country. So it is always recommended, and I suggest you all, when you go back to your units, your stations, start using modified early obstetric warning score charts, and according to the chart and color code, you escalate the problem and identify danger signs in early rather than late. So that will wind up my session. Unfortunately, I'm extremely sorry that my slides are not apparent on with you all, but I tried my best to explain what I have documented on these slides. So any questions you put on the chat box, I will be able to answer you all. Thank you very much.
Right. Thank you, sir. Dr. Jayanda Tilakaratne, consultant BOG at Dietalavan. So thank you, sir, for explaining the long process in a short period of time. If any questions, please ask on the chat box. So we go to the next lecture by Dr. Chaminda Mahuta, consultant VOG at Ms. Schoffelt, on the topic of PPH and APH. Over to you, sir. The slides are on, sir.
Okay. Dr. Chaminda Mathota, I have 20 minutes to discuss obstetric hemorrhage. It's a bit of a difficult task to cover everything within 20 minutes. So I will try to mainly concentrate on postpartum hemorrhage and management of postpartum hemorrhage, and I will discuss a little bit about antepartum hemorrhage in the next 20 minutes. So let me change the slides.
Full screen.
Can you see the full screen now?
Yes.
Or is it yeah. Okay. So the objectives of this presentation mainly as when you finish internship and goes to when you go try to start practicing your own. So how to identify the complications of pregnant women and during the postpartum period and do the necessary things. So the main objective is to identification of the postpartum hemorrhage, danger of postpartum hemorrhage and antepartum hemorrhage, danger of antepartum hemorrhage, and how to manage the principles of management. So we'll go to the postpartum hemorrhage first. Definition of postpartum hemorrhage, that is the traditional definition of postpartum hemorrhage is loss of more than 500 milliliters of blood from the genital tract within first 24 hours after the delivery. So if it is more than 500, we call it postpartum hemorrhage. But if you can classify the postpartum hemorrhage, there are two main types. The first one is a postpartum hemorrhage.